मङ्गलं कुरु जागृहि त्वं महादेवी जागृहि त्वं सरस्वती जागृहि त्वं चतुर्वेदी लोकरक्षाविधिं कुरु लोका सर्वे शुचाम्बोधौ निमग्नास्तान् समुद्धरा त्वमेवैका स्वयं व्यक्ता समर्थासि कथा भव श्रीवाणी सर्वजगतां जननि प्रमोदे जिह्वाग्रवासिनी मनोहर वेधसस्त्वम् वाञ्छाप्रदायिनी समाश्रित भक्तकोटेः
I request Dr. N. Subramanian, Director, Medical Services and Senior Consultant Urologist at Indraprastha Apollo Hospitals to deliver the welcome address.
Am I audible?
Yes.
Namaste and good morning to each member present this morning at this well-structured, well-organized program of Avatar. You know, we are all aware that all the developments in medicine, all the progress that has been made till date has come out of our commitment to clinical excellence, commitment to research, commitment to sharing of information and knowledge, commitment to training. So clinical excellence, research, innovations are important, but they will benefit mankind only if you and I share the information, disseminate the information to the last individual who's providing the service. So I can see a tremendous commitment that on a Sunday morning for us, a Saturday night for some in some parts of the world, perhaps an early afternoon of Sunday in some parts of the world. But the fact that we have come together under the banner of Avatar is an indication that we all mean to do our best to our patients and to make the treatment of their conditions even better and easier with care and compassion. The Association of the Vascular Access and the Interventional Renal Physicians have obviously grown so rapidly during this decade. It could have only come from the leadership and the participation. I understand our commitment has extended not only to the national boundaries and beyond to the countries where there has been a lot of development in the last decade, but to every corner of the world and integrating people from beyond the nations, integrating people from the SAARC countries, from the Middle East, from Europe, from the United States. Everybody coming together is what makes it all a success. I am a urologist and I've seen the transformation of urology in the last 30 years. And I can assure you that each of these changes occurred because people like you and me came together to work together, learn together, and train together. The Apollo philosophy, Apollo, as you all know, believes in integrating every aspect of training and research through our network of 72 major hospitals across the country and beyond. We believe in delivering the best of healthcare, the state-of-the-art healthcare, because of the ability to integrate, absorb, and deliver. We are all familiar with the high magnitude of renal diseases and the outcomes of poorly treated, inadequately treated chronic kidney disease. We are also aware that in a country like ours, several people who require treatment for end-stage renal disease do not have an access at all. So I think every step in moving forward and making treatments less invasive, these extracorporeal methods of dealing with these issues, the endovascular procedures, dealing with complications like venous stenosis, I think each step contributes to much improved care of the patients. You and I know that these things are only possible if we train ourselves first and train our younger colleagues to make sure that we all deliver good quality at every level. Last but not the least, we are all aware that coming together of various specialties has been the biggest success. If you recall, medicine in the past centuries was a single dimension. We all grow into our specialities, grew into our super specialities to achieve and obtain expertise in what we did. But now we have moved on to the best dimension, the dimension where we integrate all the skills, all the knowledge, all the research, all the experience that we have gained to bring it together to provide the best for the mankind. So ladies and gentlemen, I wish you all a tremendous success, and let me thank the organizers for making me a part of this wonderful initiative, which I can see every year has been growing so successfully. I'm sure the deliberations would only need to further enhancement of quality care. Have a wonderful day of deliberations. Have a great Sunday. Thank you so much.
Thank you so much, sir, for sharing your insights with us and for encouraging us. Thank you so much, sir. So with this, we now welcome the moderator for today's session, Dr. Vinant Bhargav, who is a consultant at Sir Gangaram Hospital, Delhi. He's a fellow of the American Society of Nephrology, American College of Physicians, the Royal College of Physicians, Edinburgh, an astute researcher with an eager enthusiasm for scholaristics and mentoring fellow residents, hence making him a professional academician, has several publications at both national and international level. So we'll request you to kindly introduce us to the program. Over to you, sir.
Thank you very much, Seema, for this kind invitation. And at the outset, I'd like to thank the organizers, especially Dr. Sanjeev Jasuja, Dr. A.K. Bhalla, for allowing me to moderate this session on a very important topic, which is the management of central venous catheter stenosis, as well as tunnel catheter obstructions. I would also like to extend a warm welcome to all my colleagues and delegates who from across the globe have taken their time off to attend this avatar session. As I have been told yesterday from the sessions that we attended, that central veins are extremely important for assessment of AV fistula. And I compare the central vein to the tail of the AV fistula. So it's not just the head of the AV fistula, it's also the tail of the AV fistula, which is important when you create an axis. I would like to give a corollary of the lizard, which Mother Nature has given the tail as a defense mechanism, without which the lizard would probably not be able to distract the enemy. So without saying more, I'd like to extend a warm welcome to our chairpersons, Dr. A.K. Bhalla. Dr. A.K. Bhalla is the professor and the organizing secretary of Avatar 2020, and he needs no introduction. He is known by several people. He's the chairman and head of Department of Nephrology at Sir Gangaram Hospital, New Delhi. I'd also like to give a warm welcome to Dr. J. Balasubramanian, who's the director and the chief nephrologist of Kidney Care Center at Tirunelveli in Tamil Nadu. Sir, I would like to pass on the mic to you so that you can introduce our speaker for the next session, which is going to be for 30 minutes, which is titled as Endovascular AV Fistula.
Thank you, Dr. Vinant. Good morning to all of you. As we all know, AV fistula is the lifeline of maintenance hemodialysis patient, and AV fistula is the Achilles heel of maintenance hemodialysis. Since the invent of AV fistula by Braccio and Simino in 60s, there has not been any advancement as far as AV fistula was concerned. And we have seen ourselves in our practice of about more than 35 years, I have seen there has not been any invention as far as vascular access is concerned, as, particularly AV fistula. So now, in fact, it is good thing that interventional nephrologists and other technologists and engineers, they are all trying to do how we can improvise on whatever is conventional AV fistula. Now, I have been in practice in nephrology almost 35 years, and luckily I am making AV fistula myself, and I have made more than 5,000 AV fistulas myself, radiocephalate as well as ulnar artery, using ulnar artery as well as brachial fistulas. I have done superficialization of the vein. These are all being done by a nephrologist in our center. And our average surgical time is about 15 to 20 minutes for treating AV fistula. Now, we have to see that what are the deficiencies in this AV fistula, and if there are any complications which can be improved by some newer techniques. So now we have to have, now in last 4 years, this endovascular AV fistula concept came. And after that, there are going to be, we are seeing improvement every year. And now we have to see that what are the complications which you can prevent, like neointimal hyperplasia or thrombosis, whether these will be less, versus the disadvantages also. The biggest disadvantage I find is the cost. If I mention in terms of US dollars, our AV fistula in a costliest center will cost $250, whereas this procedure is going to cost about $6,000. So, but it is a new concept, and maybe some patients will be fit for this procedure as well. So it is my privilege and honor to invite Dr. Rashid Sharaf, who is interventional nephrologist at Medical Advisory Board, Azura Vascular Care at San Antonio, Texas. And he is pioneer in this field, and he has been using both the techniques, ellipsis as well as Everin techniques. Over to you, Dr. Rashid. We are all eagerly waiting for your lecture. Thank you.
Thank you very much, Dr. Bhalla. First of all, I don't think I'm qualified to deliver any lecture over here. I'm just gonna talk about my experience and what I know. You guys are, you have way more experience, and I think I could learn a whole lot from you. So I'm indeed humbled by this invitation, by asking me to give your talk in this esteemed forum. I totally agree that these kind of forums give us an opportunity to share our experiences. And, and with this, okay, I think I got my slides fixed. Yeah, this gives us an idea, a forum for us to share our experiences, and that will prevent us from working in a bubble. I think these sharing of experiences helps us all grow at the same time. So without wasting too much time, I'm gonna start talking about what these fistulas are. So endovascular AV fistulas. So as far as my disclosures are concerned, I'm a speaker and trainer for Avenue Medical, the company that makes ellipsis. And I'm also a speaker and trainer for Medtronics. So the first question is, why create AV fistulas? Why not just leave tunnel dialysis catheters? So AV fistulas are probably the most reliable dialysis access. They have been shown to improve morbidity and mortality when compared to tunnel dialysis catheters. There are fewer access-related infections or other problems that happens. And a well-created AV fistula will require very few interventions. And at the end of the day, it's really the patient satisfaction that they don't have to go around with a catheter sticking out of their neck or their chest. And this is something that they can easily hide. The ideal AV fistula should be easily accessible, easily cannulatable repeatedly, and should have adequate blood flows to support support hemodialysis prescription. It should require minimal interventions and should cause the fewest problems such as Steele syndrome, such as congestive heart failure, neuropathy. Sometimes there's skin erosions that are associated with fistulas, or any other kind of access problems that can happen with the fistulas. That's where the percutaneous fistulas come in. So they're minimally invasive. So just to give you an idea that there are so many fistulas that we have done in our practice where the patients had actually been turned down because they were not good candidates for anesthesia. So anesthesiologists had refused to put them under or give them any kind of anesthesia. And because of the minimally invasive nature, we can do these just under local anesthesia. They require a very short maturation time. Within generally 4 to 6 weeks, we have started using these fistulas in some cases, and that has been successful. There's also a reduction in the failure rate of these fistulas compared to the surgically created fistulas. They require fewer interventions. And there's also a probable high output congestive heart failure benefit because these fistulas are created in the proximal radial artery. And because these fistulas do not have as high a flow as a surgically created fistula, there's supposedly a CHF benefit from these fistulas. We don't know that. We don't have the studies to prove that yet, but there are studies that are being conducted. There's less incidence of Steele. There are expanded AVF creation site, so where we can create these fistulas. And if at the end of the day, these fistulas don't work out, we have not really gotten rid of any surgical sites that could have been used for surgical fistula creations. Now, the disadvantages, the learning curve for the interventionalist and surgeon who wants to do this procedure, and more importantly, the learning curve for the cannulator. These fistulas are not the same kind of fistulas that, that are surgically created. They are not as bounding, as strong as the surgically created fistulas. So the cannulators, the nurses or the technicians who normally cannulate these at the dialysis centers, they find it a little bit difficult. But again, as over the past 1.5 years that we have been doing this, we have noticed that the technicians and the nurses are getting better at cannulating these fistulas. Now, as part of the interventionalist and surgeon skills are concerned, you will require ultrasound, very good ultrasound skills to not only identify the patients who are good candidates, but also to do the procedure. And also, not all patients will meet the criteria for a percutaneous fistula placement. Now, just like Dr. Bala pointed out, there have been no innovations in the past 50 years, ever since Semino and Brescia identified or created the initial fistulas. There really have been no innovations up until now. AV fistulas, the traditional sites are the radiocephalic or proximal radial or the Grax fistula, the brachiocephalic fistula or the brachiobasilic fistula. These were the only sites that were available to us. Now, with these percutaneous fistulas, what we do is we require on the perforator vein. What is the perforator vein? It is a vein that connects the deep venous system in your forearm to the superficial venous system in your upper arm. So basically it lifts the blood that is circulating in the radial and the ulnar and the interosseous veins and brings it up to your cephalic and basilic veins. So we rely on the perforator vein to create this connection. And that gives us a few additional sites where we can create this fistula. One of them is the ulnar artery, ulnar vein site, and the radial artery, radial vein side, which the wavelength system uses. And the ellipsis basically relies on creating a fistula directly from the perforator vessel to the radial artery. So the perforator vessel actually dives down right at your antecubital area from the median cubital vein and connects to the deeper vessels. So as it's diving down, it abuts or travels right next to the radial artery, or the proximal radial artery. And that is the site that we use to create the ellipsis fistula. So who is a candidate? Patients who have a good inflow, meaning arterial sizes more than 2 millimeters. And when I say artery, I'm talking about the artery at the site of creation, which would be a proximal radial. Patients who have good outflow, superficial veins more than 2.5 millimeters or 2 millimeters. An adequate perforator vessel, again, 2 millimeters is the size that we look at. And patients who have adequate creation site. So if you have a good vessel at the creation site, at the point where the fistula would be created, but the ulnar or the radial artery does narrow down as it goes down into the forearm, they would still be good candidate. So they might not be a good candidate for a radiocephalic fistula, but you could still create a proximal radial artery or the ellipsis or the wavelength fistulas. One of the things that we have to look for in these vessels are the outflow vein dominance. So if the dominant flow goes through the basilic vein, these fistulas will actually turn out to be basilic dominant. Now, will they require transposition? Not always, and I'll talk about that towards the end of our discussion. But ideally, what we look for are patients that do have good cephalic outflows. And that makes our life very easy and the life of the technicians and the patient as well. So as you can see, the surgical fistula requires an open incision, and it's a direct connection between the artery and the vein that's surgically created. With the endo-AVF, the wavelength requires radiofrequency energy, where the radial artery and radial vein, or the ulnar artery and the ulnar vein, they're approximated with the help of magnets, and a hole is burnt. With the ellipsis, it's actually thermal energy that's used right at the point where the perforator vein is crossing the proximal radial artery. So again, I'm gonna talk about some of the data from the US perspective, so you will have to excuse me on that. But the Food and Drug Administration is the key agency over here that approves the use of any drug or any procedure. So after studies that were done for many years, and most of the studies, initial studies, actually came from South America and Europe. And after having gotten approval in Europe, I think in 2016, in June 2018, FDA finally gave approval. Then finally they decided in January 2019 that they would start paying for this as well. Then further data started to come out. The 2-year ellipsis data started to come out as well. ASDEN, which is American Society of Diagnostic and Interventional Nephrology, they finally came out with a white paper. In January 2020, there was a meta-analysis that showed how these fistulas work. And since then, there have actually been so many papers that have come out that have shown how these fistulas work. Now, I'm gonna make it very short and simple. My goal is not to train you how to do these procedures, but just to give you an overview. So the wavelength is a 4-French system that requires 2 catheters. So you will either access the brachial artery and brachial vein to go ahead and direct your catheters to the radial artery, radial vein, or the ulnar artery, ulnar vein. Or you can access from the radial artery, radial vein in the distal forearm, or you could actually access one catheter in the radial artery, the other one in the brachial artery and the brachial vein. So there are many different ways and permutations and combinations that you can use this. It requires radio frequency. You do require X-ray, meaning fluoroscopy for this. And you require both venous and arterial access. There is no fusion of the anastomosis. So meaning that it's radio frequency that creates a slit between the artery and the vein. And at the end of the procedure, as you're pulling yourself out of the brachial artery, or the brachial vein, I'm sorry, we usually end up coiling the brachial vein to reduce the flow from there and direct the flow to the superficial vessels, namely the basilic and the cephalic veins. The ellipsis vascular access system, it's a single catheter, 6 French system that's ultrasound guided. It's purely ultrasound guided. There is no X-ray, there's no fluoroscopy involved. It's just purely venous access. So most of the time you end up accessing the median antecubital vein, and you guide your needle down through the perforator to the point where you directly puncture into the radial artery. And from that, you use the catheter, the ellipsis catheter, that has a ceramic plate, basically, that helps to permanently fuse the anastomosis. In this case, what ends up happening is you require a PTA at the time of creation. So after we have created the fistula, which usually is almost about 2.5 millimeter in width, we use a 4 or a 5 millimeter balloon to angioplasty the anastomosis immediately after creation. So when it comes to the comparison, I basically talked about the details of this. We require thermal energy for the ellipsis, radio frequency for endovascular wavelength. The creation site is the perforator vein and the proximal radial artery. This could be radial or ulnar. The perforator has to be more than 2 millimeter. The creation site has to be less than 1.5 millimeter apart between the artery and the perforator vein. In the wavelengths case, it does not matter if the perforator is far away from the proximal radial artery, because you're not creating a connection with the perforator vessel itself. It requires ultrasound on the ellipsis side, and this requires fluoroscopy on the wavelength. Now, even though this does require fluoroscopy, you have to screen these patients with good ultrasound technique. Now, the technical success for these patients is almost 95 to 97% for the avenue, 97 to 100% for the wavelength. And this is the meta-analysis that I was talking about earlier. The maturation rates at 3-month time is almost anywhere from 85 to 100%, 91 to 96% for wavelength. The time to dialysis on an average is about 100 days for the ellipsis and 112 days for wavelength. And I think, and this is something that we saw in our practice as well, the major hurdle was training the cannulators or the nurses or technicians. Once they got trained this time, in our practice, it was almost 160 days when we started doing this. From that, we have actually brought it down to less than 60 days now from the time of creation. Now, these patients or these fistulas, both of these techniques, the primary patency is not as good. So they do require some additional work. But the cumulative patency you will see is almost 87% for avenue and 84% for wavelength. And the patient eligibility, like I talked about earlier, that not all patients meet the requirements for creation of these kind of fistulas. There are about almost 45% patients for BARD and about almost 44% for wavelength. Now, at the end of the day, if I were to give a one-line synopsis for all the papers that have been published so far as the differences between these fistulas are concerned, I would say, other than the technical details, other than the act of creation of these fistulas, the fistulas that are created are exactly the same. The site might be different where the fistulas are created, but the technical success, the maturation rate, the 6-month patency, the 12-month patency, procedure-related complications, they're very similar. The wavelength, they tend to have a little bit more complications as compared to the ellipsis, mainly because you're accessing the artery directly. But other than that, really, the fistulas are basically the same. Now, I wanted to actually show this study, the comparison between surgical and endovascular hemodialysis AV fistulas. So these fistulas, whether you compare them to each other or to the surgically created fistulas, are very similar. And the cost in the US of creating, now I know the cost in India is totally different, but the cost of creating a surgically placed fistula compared to an endovascular fistula is significantly different in favor of endovascular fistula, because these patients do not require going to the hospital. They do not require any pre-surgical major interventions or major clearance. They do not require maturation procedures as much as the surgically created fistulas. The cost tends to be lower. Now, that might not be true, and that is, I would say that is definitely not true in your market, which would be extremely different. But as you can see, the difference in expenditure is almost $16,000 for a surgically created fistula versus $13,000. And in the long run, these fistulas have been shown to require fewer interventions as well. So as you can see in this slide, the main thing that I wanted to show is the intervention-free survival. If you can look at the graph. So if you look at the survival, the endo-AVF require fewer interventions compared to the surgically placed fistulas. Now, why that might be so, whether because you're directly mobilizing the vessel, you can cause juxtaanastomotic endothelial damage at the time of creation, whether you're transposing the fistula and that causes further endothelial damage, we really don't know, to be honest. But they require far fewer interventions and tend to be way more cost effective compared to the surgical fistulas. So as I had said, the ASDEN had put out a white paper, and it basically says, in order to realize the potential advantages of percutaneous AV fistula creation within our hemodialysis patient population, it is critical to select appropriate patients and ensure adequate patient and dialysis unit education. And I would underline dialysis unit education because our technicians still do not understand these fistulas well. They need to be provided with sufficient instruction and percutaneous AV fistula cannulation and monitoring. Uh-oh. Sorry, I think I messed up on the slides. Just give me one sec.
You'll have to share it again, I think.
Yeah.
Share your screen again.
I'm sorry about that. Can you see the slide?
Not yet.
I am so sorry about that.
No problem. Please take
But
your
it
time.
should be, yeah.
I think the slides that I had saved. Oh my God, this is embarrassing. They somehow got erased. And I might, if you'll bear with me for a second.
Yes, you have it in your
If
mail. If you have in your mail, you can take it from your email.
If Ashwin has backup slides here, they can share it.
Yes, yes, I think Ashwini.
Yes, sir.
No, unfortunately, I had not shared the final set. Now, while we are talking about that, let me just go on and say that as far as our experience has been concerned, over the past 1.5 years, we have actually created about almost 250 fistulas. And of those, about 200 are already in use. And the latest of these is actually, or the earliest that we have used these fistulas is about 4 weeks. So
I think it is already 10 o'clock and we have 15 minutes for question answer session. And there are going to be a lot of questions. So I will request Dr. Bala to have the chat box questions, and then we can get questions from the delegates. That will be much more to have interest.
To be honest, this is pretty much it as far as my presentation is concerned.
Yeah.
As far as the video is concerned, if somebody wants to watch the live video, I had done a case for at the National Kidney Foundation meeting, a live case, and that video is actually recorded both at the NKF site and at the Ellipsis website. So I would highly encourage you guys to go and watch this. The other point that I wanted to make is the average time for creation of the ellipsis fistula from the time I actually make the puncture with the needle is about anywhere from 5 to 10 minutes versus for the wavelength, it can take anywhere from 30 minutes to up to 2 hours. So that's the final point that I wanted to make.
Yes. Thank you, Dr. Rashid. Although there were difficulty in the slides, I think you have made your point. You have given an unbiased opinion about this. And although the cost appears, a vast different from open surgery in our country, ultimately the cost may not be the factor. If only this is going to be advantageous in other factors, I think over time it would pick up. So there are some questions from audience, and I have some my own questions. So I'll start with Dr. Manikanda Prabhu. How maturation is confirmed, whether clinically or by flows in Doppler in this endo-AV studies? So
our primary thing that we look at are blood flows with Doppler. So anytime we see that the blood flows are about 800 to 1200, we feel that this is strong enough. But at the same time, that is not the only thing. Just having good blood flows, and this is the brachial artery blood flows that I'm talking about. Just having good blood flows is not good enough. If you do not have a good vessel that can easily be palpated, that could easily be cannulated, then we do not release these fistulas for cannulation. So what we do is most of these fistulas will require 1 or 2 additional procedures. One of the procedures that we do is brachial vein coiling, because after you create the fistula, the blood is flowing in the proximal direction towards the heart through every outlet. So you have blood flowing through the brachial veins, you have blood flowing through all different kinds of tributaries, you have blood flowing through the cephalic and the basilic, and ideally what we like is blood to flow through the basilic and the cephalic. So sometimes we'll coil that. The other thing that we do is sometimes we'll go and angioplasty the anastomosis with a 6 millimeter balloon if the blood flows are not adequate, and only if the blood flows are not adequate. And generally that takes care of that. Sometimes if the superficial blood vessels are still quite deep, One of the things that I do is something called liposuction, where I take a simple liposuction needle and just suction out the fat between the skin and the blood vessel. And in most cases, that's more than enough, and we don't have to transpose the fistula. Does that answer your question?
Yes. Then I wanted to ask you some questions. How consistent is this perforator? Is that the factor which precludes many patients from doing this procedure? You said only 45% qualify for this procedure.
Yeah.
What is the fit for this? What are the factors?
Sure. The perforator is actually pretty consistent. So almost 80 to 90% of us do have perforators and do have perforators that are actually pretty good. Most of the cases that we reject are patients who would not be good fistula candidates anyway. So these are patients who have poor outflow tracts, either poor basilic vein or poor cephalic vein, and they would end up requiring some kind of an AV graft rather than a fistula. By the way, I wanted to make this point that if the patient is a good surgical candidate and a good candidate for a percutaneous fistula, we always give the patient the option to choose between the two.
When you say coiling for side branches, is it done in the same sitting or it has to be taken up later? Is it taken up later?
Generally, we try not to how should I say, not to lose or make useless any of the blood vessels. So generally, we will create the fistula, except for the wavelength, which requires coiling at the time of creation. For the ellipsis, we don't usually do anything at the time of creation. So if the patient comes in, has good flows, has a nice, palpable cephalic and basilic vein, most of the time we'll say, go ahead and start using it. Now, keep in mind that these fistulas will actually give you, since they're created in the proximal radial artery, they will give you additional sites. So you can actually cannulate some of these fistulas below the elbow as well. So no, they're not done on the same setting.
Then I find one small paradox. You say the anastomosis is shorter in this compared to open, and the fluid is not so exuberant to cause hyperdynamic circulation. But
Yes.
on the other side, you say maturation is better with this endovascular technique compared to open. I mean, these two, I think they're slightly paradoxical like that.
Yeah, exactly. So, and again, that is something, to be honest, that is something that we might have to revisit when we say about maturation. We normally wait a long time for our vessels to get arterialized. What we have noticed that they don't have to become super arterialized before we start cannulating them. So if we start cannulating them with a 17 gauge needle, these fistulas have worked well, especially since you are actually in patients where we access both vessels. So if let's say the arterial needle goes in the basilic vein and the venous goes in the cephalic vein, they tend to tolerate initiation much earlier than the single vessel ones.
Then there's another question about the leaks and hematomas. Even in open anastomosis, we do sometimes see. What about this? This is simply, percutaneous. So, what happens?
Yeah, if you remember my slide that shows that about 5% of the patients had some complication, I would say about 1% of those complications are hematomas or leaks at the time of creation. Some of them, because you're using either thermal energy or radiofrequency energy, sometimes there have been cases with wavelength where they've actually developed pseudoaneurysm of the artery where this fistula was getting created. I have had personally 2 cases where pseudoaneurysm got created in the perforator vein. But again, most of these complications are not major. Even the hematomas, sometimes at the time of creation, there would be some blood leakage, there would be some hematoma, but most of the time the hematoma is easily controllable and really has not been a major factor.
Especially when you do PTA on the same day of creation in one of these methods.
Surprisingly, I was extremely skeptical the first time I did PTA. I was like, I just created this fistula. You want me to do PTA on this with a 5 millimeter balloon? But they hold very well. They do very well with the PTA. I know I was the same way, that you want me to do PTA right at the same time, but that's what they have done, and they do very well.
Any instances when you had to call the surgeon to help you out with hematomas?
Not really. No. Like I said, I have had 2 cases where the perforator vessels did develop pseudoaneurysms. We did send them to surgery or to the surgeons to consult upon them. They recommended watch and wait. So after a few weeks, the swelling that they had in their arms, that settled down, and we really did not have to intervene surgically.
Dr. Kishore Dharan wants to know the incidence of Steele syndrome in this.
You know, so far we have not had any cases of Steele syndrome.
Steele syndrome in
Yeah. So far we have not had any cases of Steele syndrome, but there have been a few cases that have been defined. I think the cases of Steele syndrome are about 1 to 1.5% in the papers. In my practice, we have not had any cases of Steele.
Dr. Shailendra Shrestha wants to know, in case you need to close this AVFs, how do you do that at a later date?
Close the fistula?
For some reason or other.
Yeah, that would be a challenge. So that would have to be done surgically, where you would actually have to open and dissect down to the perforator vein where the connection has been made. Because if you consider the anatomy, that there are all these different blood vessels that are coming off. So if you close off the cephalic, if you close off the basilic, there's always still flow that's going up the brachial veins into the radial ulnar veins. So you would have to actually dissect all the way down to the anastomosis to close it down.
Then in case, you have done it in a proximal site, and later you plan a distal AV fistula by either this method or by open, is that a problem?
No. So we have actually, we have had a few cases where we created the fistula did not work. There was a primary failure. Almost, I would say about, of the 250 or so that we have done, there were probably about 3, maybe 4 patients that had primary failure. We sent them, and they were good candidate for a distal radiocephalic fistula, and that was done. There, and then there was another patient that we had initially created a wavelength fistula on that did not work. We went back and did a ellipsis on that patient, and that worked. So the good thing about these is that it really does not destroy the vessel. So you can actually use and reuse and do everything or anything that you want with it.
And I guess most of the time you end up doing proximally, right? I mean, how many times do you choose distal radiocephalic rather than, your brachial and proximal ulnar or radial artery?
So when it comes to the ellipsis, there's only one site where you can create this fistula, which is the proximal radial and the perforator. With the wavelength, you can actually, if the vessels are big enough, you can actually go further down proximally. But the problem is, with the wavelength, it's basically a series of magnets that help to kind of align the blood vessels together and approximate them so that when the radio frequency wave is sent, it creates that slit in there. The problem is that sometimes as you go distally, the vessels can move apart and they might not be too close to each other, where you might not get a good anastomosis site. So these tend to be, again, in the mid forearm. The anastomoses with the wavelength tend to be in the mid forearm, not all the way down by the wrist area.
Any other questions, Dr. Balla? I'm trying to see the list here. Steele syndrome. How densely calcified vessels? Yeah, that is a good question.
That is one question.
Yeah, presence of calcification in the arteries. Will it come in the way of this, the fistula creation
Yeah,
and complication?
yeah,
Calcification of the
If you have
artery.
calcified vessels, arteries, whether there is a contraindication?
For the ellipsis, no. For the wavelength, the cases that have been defined where the patients actually did get pseudoaneurysms, uh, what the paper said was that it might have been because the vessel was calcified. With ellipsis, honestly, I have personally done or created fistulas where the vessels were, significantly calcified, and we really had no issue with that.
Which method you will prefer personally out of the two?
So just to give you an idea, out of the 250 plus cases that I've done only about 10 or so of the wavelength. Okay. I think that answers the question. And the primary reason is, like I said, at the end of the day, the fistula that is created is pretty much the same. It's the ease of creation and the time that it takes. So ellipsis is so much better when it comes to the time.
Right. Thank you, Dr. Rashid. I think it was a wonderful session. And many times what I have seen is many new procedures like this at the beginning will look far-fetched and may not be relevant to us. But as time goes by and once you get to see it on first hand and start doing it, sometimes you feel, it has relevance in our situation also. Dr. Bala, you can give your final comments. And
yes. Thank you, Dr. Balasubramaniam, for excellent question and answer session. And on behalf of both of us, we profusely thank you for the wonderful talk. And it was almost the end of your talk, so there was no problem with the slides. Don't worry, we learned a lot, and I'm sure everybody will gain a lot. And maybe by the next year, when we have the avatar, we will have our own Indian experience of endovascular AV fistula. Thank you.
Absolutely. Thank you so much, gentlemen. And thank you to Avatar for inviting me to speak. Thank you so much.
Thank you. Bye.
Thank you, sir. This has been a very enlightening session. We now move on to our next session. It is based on anatomy of central veins, antegrade and retrograde central venous catheter placement. I now invite the chairpersons for this session, Dr. Ritesh Sharma. Sir is a director and head nephrology and kidney transplant medicine at the Asian Institute of Medical Sciences, Faridabad. And the other chairperson is Dr. B.K. Upadhyay, the Associate Director, Nephrology, also at the Asian Institute of Medical Sciences at Faridabad. I now request Dr. Ritesh, sir, to please introduce the speakers for this session.
Yeah, good morning, everybody. It's a pleasure to be part of the Avatar conference and the first virtual Avatar conference this year. I must congratulate the organizers for a wonderful meeting. And it's a great pleasure to introduce the next speaker, my former colleague, Dr. Gaurav Sagar, who is a senior consultant nephrologist at Indraprastha Apollo Hospital, New Delhi. And he shall be talking on antegrade and retrograde tunnel catheter placement. And the screen is all yours, Gaurav.
Thank you, Dr. Ritesh, for the kind introduction. So I'll be starting my recorded session.
Greetings from Apollo Hospital, Delhi, and welcome you all to the Avatar 2020 webinar. I am Dr. Gaurav Sagar, Senior Consultant Nephrologist, and I'll be speaking briefly on the steps of retrograde and antegrade tunnel dialysis catheter placement. So coming to the steps of antegrade and retrograde tunnel dialysis catheter placement, this is a brief overview of the central venous anatomy, and as we can see here, the important veins which are accessed for the tunnel dialysis catheter are the internal jugular, followed by the subclavian and the femoral vein. Of course, the right internal jugular vein is preferred because it has a straighter course to the heart, gives lesser kinks and provides better flows. There are certain situations when the patient has exhausted all the vascular access. Sometimes we have to approach the translumbar or the transhepatic veins. There have been instances where we have used the azygous vein for access, and sometimes we have also used collaterals as a temporary access for the dialysis catheters. So in this presentation, I will be using the retrograde catheter from Arrow, which is the Vector Flex. This is the catheter. We can see here, this is the catheter. This is the introducer, the tunneler. This is the peel apart sheath, the dilators, and this is the hub which is attached to the end of the catheter over here. And these are the clamps which are used for venostasis, so that to prevent air embolism. So now we are going to see the introduction of guide wire under ultrasound guidance. It's a protocol nowadays that all punches have to be done real time under USG guidance. So here we can appreciate the vein, and this is the artery. So what our practice is that we try to puncture as low as possible, just close to the clavicle. And if you see the vein, we are entering the vein from the lateral aspect. If we enter the vein from the lateral aspect, that gives a very smooth curve and avoid kinks in the catheter. So you can see the needle going inside the vein. Free flow is accessed, is confirmed, and then we introduce the guide wire into the vein. As a principle, we always secure the wire into the IVC. Here you can see the wire is in the IVC. So what are the advantages of putting the wire in the IVC? First, if the wire is in the IVC, you are sure that you are in the venous channel. Second, placing the wire in the IVC reduces the risk of arrhythmias. And finally, the wire provides some sort of support so that the dilatation and the insertion of the catheter is comfortable. So after giving 2% local anesthesia at the site of guide wire insertion, a stab incision is made with a blade. Now this step is very important. This is what I always consider very important. With the help of an artery forceps, around the insertion of guide wire, we just dissect the tissue slightly, so that this is the area where generally the kinks are formed. So if we dissect this area around the guide wire, the catheter sort of tends to sit comfortably around the wire, and the chances of getting a kink are considerably less. Then the serial dilators are used and the dilatation process is done. It's important that the dilatation is always done under fluoroscopy. There are many centers who are doing tunnel dialysis catheters without a fluoro, but generally this is not recommended. My teachers used to tell me that this is the step which is most important, because most of the complications happen at this time. So all dilatations have to be under fluoroscopic guidance, and especially in the beginning of the learning curve, you have to be very careful. You don't want any complications, because you will be discouraged to do procedures further. So after the serial dilatation, the sheath is introduced, which again is done under fluoroscopic guidance. Inside, what we do is we take the catheter and we put this is the venous clamp. We put the venous clamp so as to prevent air embolism. This clamp is put here, and the catheter is then introduced into the sheath under fluoroscopic guidance. Again, this you can see the catheter going inside the peel apart sheath, and then after confirming the position of the tip of the catheter under fluoroscopy, the peel apart sheath is sort of pulled away so that we can pull it out. So here you can appreciate the sheath being pulled out. Either we can take the help of the assistant who has to keep a finger over here so that the catheter doesn't sort of migrate out, or you can keep your own index finger at this point. So once the catheter is inside, you have to recheck the position that the tip of the catheter has to be in the right atrium. The advantage of this retrograde catheter is that you can change the position according to your convenience, and you can adjust the tip so that it is in the right atrium. For our patients, the dictum is that the tip of the catheter should be about 2.5 vertebrae below the carina. So when the tip is 2.5 vertebrae below the carina, the tip is generally in the middle of the right atrium. The venous clamp, the hemostatic clamp, is then applied just close to the skin and just near the cuff so that the catheter does not migrate again and it does not change its position. So once this is done, the other end of the catheter is adjusted and it is placed on the skin so as to know where we want our exit site. So it can be approximated and we can see where the exit site has to be. Like this is the point where we will keep our exit site, and this we can see is the cuff where the original venotomy was done. So again, after infiltrating local anesthesia, a stab incision is done with the help of a blade, and then the tunneler is introduced over here directed towards the venotomy site. Here we can see the tunneler coming out from the venotomy site. It has a hand grip so that it can be assisted, and then the end of the catheter is fixed on to the tunneler. So as we close it, there is a snap which we can hear and which we can feel. And once this is done, once the catheter is fixed to the tunneler, with the help of pull and push technique, the catheter is taken out from the exit site. So now we can see the catheter is out. This is the tunneler attached to the catheter, and once the catheter is out from the exit site, what we do is we cut it with the help of a scissor from somewhere across here, about 1 inch away from the exit site, like this. So the clamp is here, the catheter has been cut with the help of a scissor about 1 inch away from the exit site, and then this is the hubs which are available with the catheter. You just have to screw on to the catheter and try to apply some pressure over here tightly so that this is the final picture which we get. So there has to be no leakage over here, and you have to do it very firmly. And then this is the end result where we see the catheter flows are very good. Now I will demonstrate the steps of the antegrade tunnel dialysis catheter placement. For the antegrade tunnel dialysis catheter placement, I am using the palindrome set which is available from Mahurkar. This is a symmetrical tip catheter. So again, under ultrasound guidance, the guide wire is introduced and we ensure that the guide wire is passed into the IVC. What we do next is that we place the catheter on the chest wall and sort of try to measure the exit point. A smooth curve has to be there so that there are no kinks. With the help of the cap of a needle, we just make a mark on the skin surface to be sure where our exit point would be. Then after infiltrating 2% local anesthesia, we give a small incision around the guide wire. As I had said before, this step is extremely important. If we dissect around the guide wire, the fibrous tissue around the guide wire is removed and the catheter sits comfortably on the chest wall, thus minimizing the kinks. Adequate dilatation being done around the guide wire. Now what we are doing is we are hooking the catheter onto the tunneler. The distal tip of the catheter is hooked on to the tunneler. So from the exit point, we put in a blunt forceps so that the tunneling process is smooth. So generally what I do is I take the tunneler and bend it so that it gives some sort of leverage when you are introducing the tunneler in the subcutaneous tissue. You take the tunneler and point it towards the venotomy site. Feel the tunneler with the index finger and then slowly and steadily with the pull and push technique, you take out the catheter from the venotomy site. This is the peel apart sheath which is available with the catheter. It has a unilateral valve inside which allows the dilator to go inside but doesn't allow any blood to come out. So we'll introduce the dilator inside the sheath and then lock it up. Now we are using the serial dilatation. It's important again to do all dilatation under fluoroscopic guidance. So serial dilatation by the catheters under fluoroscopic guidance. There are two dilators, the smaller one and the bigger one, and then you put in the sheath. The peel apart sheath is already inside, and then we will take out the dilator along with the guide wire. The catheter is then introduced into the peel apart sheath. This is also done under fluoroscopic guidance. You can see the catheter moving inside the sheath. Now we have to pull apart the sheath. We pull it apart and press it downwards. While pulling out the sheath, we have to be careful that we don't pull out the catheter, so we can keep our index finger on the catheter. Finally, we will check the position and the flows. For the catheter to work successfully, the exit site, the kinks and the tip has to be important along with a smooth curve. Again, the catheter tip has to be in the middle of the right atrium or 2.5 vertebrae below the carina. The catheter is then secured with the help of a suture and the flows are rechecked. So what are the differences between the antegrade and the retrograde tunnel dialysis catheter? The retrograde tunnel dialysis catheter offers a better tip position compared to the antegrade one. So especially in patients who are obese or who have a thick neck or who have had multiple accesses in the past with lot of fibrosis, I would prefer the retrograde tunnel dialysis catheter in place of the antegrade. Putting a tunnel dialysis catheter over the wire, and especially in veins which have been stented because of central venous stenosis, retrograde tunnel dialysis catheter again offers some advantage. There are lesser chances of migration when doing the procedure with a retrograde tunnel dialysis catheter. But yes, having said this, I would suggest whenever you are starting to do the procedure, whenever you are learning the procedure, it's always easier to start with antegrade tunnel dialysis catheter compared to the retrograde. When you begin to do these procedures, the right internal jugular vein should be preferred, and only once you have done about 8 to 10 right-sided procedures should you attempt the left internal jugular or the left subclavian veins. Another theoretical advantage of retrograde dialysis catheters is that you are tunneling from inside to outside compared to the antegrade catheters, which are tunneled from outside to inside. So probably there is some lesser risk of infections when you're doing a retrograde tunnel dialysis catheter compared to an antegrade one. Thank you all for your kind patience. We are now open to question and answers.
Thank you very much, Dr. Gaurav Sagar, for such a lucid presentation. And if I was just to summarize, you have very well demonstrated the anatomy of the central venous system and have very clearly told us different techniques to put the catheter and have made very, very simple for the insertion. You've given us important tips about how to do the tissue dissection, how to put the guide wire in the IVC, confirm the position. And now I would request the chairpersons to kindly take questions from the audience and their own questions. Thank you.
Thank you, Vedant. Thank you, Gaurav, for a wonderful presentation. And there are a few questions that have been put, and I'll direct them to you. The first one is that some centers don't use peel away sheath and do over the guide wire. Does it make a difference?
So generally the peel away sheath is available with the set. But yes, if you are changing over the guide wire, then you have to be careful that the guide wire should be a stiffer guide wire, because otherwise it can kink at the neck.
Okay. Another question is, sir, do you use the same guide wire available in the catheter set or a different one?
Yeah, so whenever we are changing the catheter over a guide wire, the guide wire provided with the sets generally doesn't work. So most of these times, then I would be using a stiffer wire, which the cardiologists use, so that over the stiffer wire, especially at the nape of the neck, it's possible to manipulate the catheter and maneuver it over the guide wire. Because the guide wire, I have seen the guide wire which was provided with the set. If you try to put the catheter, exchange the catheter over those guide wires, it generally tends to kink and doesn't give adequate support. So I would always prefer a stiffer wire or the Vena track, which is available with the palindrome set, that can be used whenever you're changing the catheter over the guide wire.
Right. Yeah.
Dr. Gaurav, good morning. Wonderful presentation. Dr. Nikhil Vasin has asked, would you try to put tunnel dialysis catheter if there is a partial thrombus in a vessel?
Yeah, that's a good question. So what we can do is sometimes it depends where exactly the clot is. And when you have put in the guide wire, you can take an angio shot by putting in a 4 French or a 5 French catheter, a 5 French sheath. So if you can manipulate the wire and the wire can go into the IVC, so and there you can take an angio shot. I think we have done catheters with a clot upstream also, so that should not be a problem. But of course, these tunnel dialysis catheters are a second preference. If you can do a fistula or a graft, they're always considered the option. They're always considered the option for dialysis.
Definitely, there are some.
There would be instances when, yes, perm caths would be forced upon you, tunnel dialysis catheters would be forced upon you. So in these instances, if you can pass the wire and the clot is not causing any obstruction, of course, we can put in the catheter.
Very good. Next question is, how do you accurately determine the exit site in antegrade approach, given that initially we are determining the tip position based on the surface of anterior chest wall, and after insertion, it is either a bit more deep in the right atrium or at times in IVC? This is a question from Dr. Shravan Kumar.
Yeah, so you can measure the catheter also beforehand. So generally for Indian patients who are around 5 feet to 5'7", I would use a catheter of 19 centimeter. But yes, anything more than 5'8", 5'9", of course you have to measure over the chest wall also, because somebody may be having obese, they may be obese, may be having a lot of muscle or fat. So, but important is if you are deep into the RA or into the IVC, there is always an option to pull out the catheter. And at the end, at the chest wall, you can make an incision and you can embed the catheter inside the tissue. But yes, if the catheter is falling short of the right atrium, then I would prefer a repeat puncture and would do the procedure again. If you are too deep in, obviously you can pull it out, but if you're outside the right atrium, a deep puncture would be required.
One more question from Dr. Venkat. He is asking whether do you recommend stiffer wires for the left-sided Pomacats as compared to right side?
Yes, especially when you are learning to do these tunnel dialysis catheters, you have to remember that left-sided can be more difficult. When you see when you're putting the guide wire under fluoroscope guidance, you realize that there are two curves. The guide wire first is the superior curve, and then there is an anteroposterior curve also, which happens. So at that point, when there is the anteroposterior curve is there, the guide wire, it can be difficult to do the dilatation process. You can use stiffer wires, but stiffer wires you need a lot of experience because they can perforate the vein also. And second, on the left side, sometimes what I do is I slightly bend the dilators so that they take the course of the vein and dilatation process becomes easy. Important is that most of the complications happen during dilatation. That is the time you have to be really careful. And at
Yeah.
that time, you have to there should be some tensile strength in the guide wire. You can ask an assistant to pull it slightly so that it is slightly stiff. Because if the guide wire is lax, then the dilator can perforate the veins. It's always important to remember that dilatation causes maximum complications. And especially on the left side, you have to be really careful. But again,
Um,
stiffer wires have to be used carefully because they themselves can also perforate the veins.
just a personal question. Which company Tomacat you are using actually? Because guide wires, dilators, everything it is inside the set. So
So at our hospital, the antegrade, we are using Palindrome and the Maxit, which is available from Hooker. And the retrograde we are using from Arrow, which is Vectorflex.
what is your view of cannulating external jugular veins?
So if the IJV is blocked, I don't have any personal experience, but a lot of people are doing external jugular dialysis catheter also. So I have seen Dr. Mehta doing number of external jugular catheters. So if the IJV is blocked, then of course the EJV, the external jugular vein, becomes prominent. And
There is any
then
chance of
you access the EJV.
EJV? Okay. Suppose internal jugular vein is thrombosed, then cannulating external jugular vein is not going to cause some supervena cava. Just my they are not going to cause any supervena cava syndrome kind of.
See, it all depends how much obstruction is it there. Is it partial obstruction or is it causing complete obstruction? Obviously, if there is a thrombus, we would like to avoid, but there are situations when you are forced to do these tunnel dialysis catheters. And if the tunnel dialysis catheter is there, it is always going to be thrombogenic and would always propagate the clot.
Dr. P. Chakravarti has asked about pediatric experience. He has noticed that peak avesis does not have valve when there is a torrential hemorrhage in pediatric Pomacats. What is your experience of pediatric?
No, I don't have any experience in pediatric, but the adult catheters which are available, the peel apart sheets have improved considerably. There is no bleeding as I had shown in the video also. So they have a unidirectional valve. So the catheter, the wire can go inside, but it doesn't cause any bleeding whenever the peel apart sheet is in the vein. So that way there is a real advancement in these peel apart sheets.
There is a
I remember when my seniors were doing it, there used to be a lot of bleeding when the tunnel dialysis catheter were being done.
Definitely.
But I don't see that bleeding whenever ever since this unilateral valve peel apart sheath has been introduced.
One more question from centers with not much of readily available cath labs. Dr. Shravan Kumar has asked that how we can do without fluoroscopy that this Pomacath is put in RA only and not in IVC.
See, the C-arm is most of the times available in operation theater. We can use that also. But if you are in the beginning of the learning curve, I would strongly discourage that you should be doing it without fluoroscopy. Because if you're trying to sort of dilate without fluoroscopy, there can be complications. And if complications happen at the beginning of the learning curve, I mean, you get discouraged. There are many centers who are doing without fluoroscopy. And I would suggest if there is no fluoroscope, then at least there should be an experience radiologists who can at least confirm, or you should have some training in ultrasound so that at least you can confirm where the tip is. Although it's not easy to confirm on ultrasound the SVC, the central veins, and the right atrium, but still it does help to some extent. But I would suggest that all tunnel dialysis catheters should be done under fluoroscope guidance.
Next question from Dr. T. Chakravarti. How to manage tract bleeding, which happens sometimes post-catheter insertion as blood comes out of the exit side? I mean, sometimes after insertion, we do see bleeding from the tunnel side.
See, that requires only compression, and you have to suture. Most of the times the bleeding is from the exit side. It's from the venotomy side. So if you give pressure at the venotomy from where the guide wire had entered, you have to give pressure there and apply a suture there. That takes care of most of the bleeding. But I always dilate, but I always dissect around the guide wire because that really minimizes the risk of kinks. But yes, when I'm completing the procedure, I would give a suture around the point where I had dilated also.
Dr. Raghavendra Singh is asking, he has faced a problem with retrograde placement when connector rings were not suitably fit and showed leakage. Maybe it was in his first use. What to say?
Yeah, initially for the first two catheters, I also had this problem. But the catheter, the retrograde catheter, which we are using from Vector Flex, it has a green sheath inside. And you have to be careful that when you are screwing that over the green sheath, it has to be done very firmly. So once you start doing it, once you start using this catheter, you realize that yes, he's right. Actually, this is a point where you have to be firm so that there is no, it has to be screwed properly over the catheter in the proper, the screws have to be proper. It should not be bent, it should not be crossed. And this green part inside has to be over the catheter. So once you do it, you realize, I have videos on YouTube. You can see the videos on YouTube where they are doing the retrograde catheter where the green tip is there inside. So that has to be screwed properly.
Dr. Vinant, do we have more time to ask? Because there are 2-3 more questions.
If you can just run through them fast, but I think we're almost run out of time.
Yeah. Dr. Ramesh Jain is asking, what will be the ideal approach in a clinical scenario when the patient is showing signs of SVC syndrome with functioning pharmacats?
Oh, that's a very difficult question because if you have, if you don't have any access, then what you can do is you can attempt SVC angioplasty. You have to dissect the catheter, make it free, pass the wire, and attempt angioplasty, and then the same catheter can be put back in. Or you can try the lower limb if the expertise for SVC angioplasty is not there.
I think we have more questions, but we should conclude the session because we have many more in waiting. Thank you very much, Dr. Gaurav, for excellent presentation. Thank you, Dr. Vinant and the whole of our team for involving us. Thank you very much.
Thank you.
Thank you, sir. This was definitely a very, very interesting session. Moving on quickly to our next session, which is the third for the day. The session is on hardware for fistulography and fistuloplasty, angiography and angioplasty. I now call upon the chairpersons, Dr. Dilip Halla, who's the director for renal kidney transplant in Max Super Speciality Hospital at Patparganj, Noida, Vishali, in Noida and Vishali, and Dr. Ravi Bansal, who's the senior consultant nephrology and kidney transplant physician at PSRI Hospital, New Delhi. I request Dr. Dilip Halla, sir, to please introduce the speaker for this session.
Good morning, people. Good morning, all the delegates, and good morning to Dr. Adil. I think after an excellent session on tunnel catheters, we'll move on. And we have no one better to speak about this than Dr. Adil Beg. He's an alumni from from Apollo Hospital. I would say the organizers of Avatar, and I think he's the right person to give us this talk. Also, he has had done 1 year fellowship in intervention, nephrology, and CMC Vellore, so totally a homebred person. Presently, his services are being done in the Khyber Hospital in Kashmir. So without any ado, I would request Dr. Adil Beg to please take over and start the presentation.
Morning. Thank you, Dr. Balla, for your introduction, kind introduction. I'm now going to start my recorded video. Thank you. Hi everyone, I'm Dr. Adil Beg, Consultant Intervention Nephrology, Apollo Hospital, New Delhi. I welcome you all to Avatar 2020. So today we are going to discuss about the hardware used in the Cath Lab. Now we are going to learn about the hardware of the used in the Cath Lab. This is the first thing. Imagine your patient is ready, it's draped, there's a site is prepared. Now we have to cannulate the vessel. It can be femoral, it can be the radial. So the approach, or it may be the fistula. So this is the micropuncture needle set. So the micropuncture needle set is a radial one. So micropuncture needle set contains a micropuncture needle. It may be the 18 gauge for the femoral or the 22 gauge for the radial. It contains a sheath with the side arm sheath and the valve sheath, and then the dilator and a small syringe. So imagine that your patient is ready for the cannulation, and imagine this is the femoral artery, this is the introducer needle, this is the 18 gauge introducer needle. So I will put the needle, I will cannulate under ultrasound guidance, I will cannulate the femoral artery or femoral vein. Then this is the guide wire. This is the J-tip guide wire, introducer guide wire. This is the short length around 30-40 centimeters, and this is the straightener. So I'll straighten it so that it can accommodate into the needle. So I'll put the guide wire. This guide wire is inside the vessel. I'll remove the needle, check the guide wire in the vessel by fluoro. This all under fluoro, and I will prepare the sheath. This is the dilator of the sheath, and this is the sheath. So sheath has few parts. One, this is the open hollow sheath. It is a one valve, it's a cap and with the one valve, and second is a side arm with the double lumen outlet. This outlet and this outlet with the valve. So this is the 6 French sheath, it's green colored. So this dilator, it has a click sound on it. It has a one serrated portion. So we'll put inside the sheath, the dilator inside the sheath, and we'll notice a sound. This is one sound. We can notice that it's fixed to the sheath. It will not remove like this now. Now I will put the sheath inside the vessel like a circular rotating movements, and then I will remove the dilator and the guide wire. Now the sheath is inside the vessel. I will flush it with the saline, check the flow, see the patency of this, and then put a heparin. Then with this we have secured the access. So the access is femoral with the 6 French sheath. Now imagine if the sheath is in the fistula or in the radial artery or in the femoral vein. So I have to take the angio of that vessel. So I can put the dye on through this port only and take the angio or take the fluoro of that area.
But if I want to take the flora of the central vessels, for example, or my approach is from the femoral and I have to go to the brachial region. So from the femoral, I will put, this sheath is very small. This is very, it's around 6 or 7 centimeters. So I will go through the help of something to the brachial region and scan this area. So that will be the guide wire. So this is the straightener. I'll put here and put the guide wire inside it. This is the guide wire, is the Terimo hydrophilic guide wire. Just now we'll learn about this. So this guide wire, I will advance to the desired vessel. So for example, I have to go from the femoral through the inferior vena cava, right atrium to the superior vena cava, then the brachiocephalic, and for example, the left side of the fistula, in the left basilic vein, and through there to the cephalic vein of the forearm. So we'll learn about this. This is the Terimo guide wire exchange length. This can be 80 centimeter, this can be 240 centimeter, or 380 or 400 centimeter. We'll get the exchange length Terimo guide wire. This is the hydrophilic coating. The hydrophilic coating means that when we put it in the water or the saline, it becomes slippery. This is a hydrophobic. It allows water, so it becomes slippery. It can move easily into the vessels. So we have now put the guide wire to the desired tissue, and on the guide wire we can put the catheter. These are the catheters. This is the 5 French angiography catheter. This is the multi-purpose catheter, MPA, that is multi-purpose catheter. It has the catheter has its curves. So this is the primary curve, this is the secondary curve, and some has tertiary curve. Like this catheter, it has one, this is the primary curve, this is the secondary curve, and this is the tertiary curve. So they have 3 curves, 1, 2, and 3. It depends on the vessel, which catheter you are using. In intervention nephrology, we use multi-purpose catheters, because this is the straighter one. This is the diagnostic angio catheter. Now there's a guide wire. We'll advance on the guide wire the catheter, and we'll take an angio of that place. This is for central vein angio. This is for the angio of the fistula. We can take fistulography. We can go for the central venography. So if I want to take now for the patient, I found that there is a stenosis and I want to do the angioplasty. So for angioplasty, we use balloon. So this balloon is 5 centimeter long and 5 mm in diameter. So this is the plastic sheet on it, and it is connected to this thing. There is its rated burst pressure is 14 atmospheres. It's written here. So my inflation device will be attached here. So this balloon will be inflated. This is the inflation device, and this is for the guide wire. So I'll put the guide wire through this. It will be advanced on the guide wire. So guide wire, it is, if I want to do the angioplasty here, I will advance on the guide wire. I have put it on the place. Then I will attach the inflation device. First we'll discuss the inflation device. This is the inflation device. It is a valve and it has a meter. So how many atmospheres we are pushing. How it is used, this limb we have to put into the contrast, which is diluted with the saline. Press this one and then suck the saline in it. We can keep it in 10 or 15 ml. So now keep this is now negative, attach with the balloon, and then we can see the balloon. See the balloon. This is now inflated, so we can go 2, 3, 4, 7, 8, and we'll see the lesion. We'll see the stenotic lesion dilating. This is how we use the balloon. This is how we use the inflation device. So this is the 90 centimeter balloon, long limb, with a 5 centimeter long balloon with a 5 mm diameter. This is the inflation device. I have used it. So we can deflate the balloon and then remove it. Now at the end, we have done our job. We have done the angiography. We have done the angioplasty. We have removed all the hardware. Now we'll press on the skin and remove the sheath. And this has completed, and put the dressing, tight dressing on it. And this has completed our procedure of angiography or angioplasty. This was the hardware used in the
So are we through with the presentation?
Yes,
Yeah.
Dr. Adil
So,
Beg, thank you very much for your presentation, in which you have very well summarized about the different sheath methods, how to insert the contrast, the Terimo guide wire, and also the different curves of the catheter. And the most important thing is you have in a very simple manner, you have explained to us how to do an angioplasty. And I'd now request Dr. Dilip Bhalla and Dr. Ravi Bansal sir to kindly take over.
yeah, I think Dr. Ravi, you can take over the questions.
Okay, very nice talk, Dr. Adil. Actually, I had one question. First thing is that a lot of these patients where there's a AV fistula dysfunction, we can evaluate by clinical examination and ultrasound.
Yeah.
So what would be the indication where you feel that we should refer the patient for fistulography? Or what are the patients where you will like to subject them to fistulography?
Okay, there are few things that the clinical things that have proved that when you feel that clinically this is a dysfunctional fistula, the finding on the ultrasonography Doppler is pretty consistent with the clinical setting. Then the plasty should be done. First thing is that there's a average time, bleeding time is more. When there is a poor flow, there's a suction at 150, 200 flow, it's not sustaining flow up to 300. And there's a poor thrill, whether the inflow stenosis you are feeling or the juxtanostomatic stenosis. These are the very few indications that we should go for the screening for the US ultrasound Doppler, and then the angiography at least. And if we found the lesion in the stenotic lesion, we should plastate.
Okay, another question, another comment from the audience from Dr. Ruchi is that while you put the introducer and put the catheter, then you should have a suture, a purse string suture or some compression in that area. Do you follow that in all the patients or only in arterial lines or venous lines?
No, generally not. I'm not following that when I do the plasty in radial artery or in the femoral vein. No, not for that. But yes, when I'm doing the thrombectomy of the graft, yes, I do that. I put the suture on the small sheath. You cut the sheath, a small piece of a sheath, and then put the purse string suture on that, and then tight, and leave the part of that sheath there. And next, on after 24 hours, you remove that.
Okay, if we have to approach or image the vessels for a distal upper limb fistula, which is the most common scenario, then how do you access those veins or the fistula? Do you access from the lower limb or can we cannulate from the upper limb? What do you follow? Like from the fistulas, the veins or the radial artery or from the femoral?
Yeah. For that, if there is a segment of the radial artery, I felt that now I'm doing daily practice of that. That I go through the radial artery, put the radial artery sheath, 6 French sheath, and you can put any hardware through the 6 French sheath. Yes, radial artery is the best access for the upper limb fistulas, the distal fistulas.
So you will go in direction of the wrist or you will go towards the heart. In which direction and which side you will enter, from the cubital fossa or below that in the forearm?
No, I will go in the radial artery. I will go at the wrist, cannulate towards the heart, and just like a angiography done by the cardiologist, we go through the radial artery, put the sheath. You have to put the just part of the sheath because otherwise it will pass the fistula. So put the guide, put the first check the angio and put the guide wire, and you can do your work. If, for example, there's a mid-body AVF fistula or juxtaanostomatic fistula, it's easy way to get the angioplasty of the fistula through the this radial artery. If in some situations there's a radial artery is very short, it's actually for example, its fistula is on the wrist, or there's a no part of the radial artery to enter. So that in that situation I prefer to go through the fistula, from the cephalic vein of the fistula, and just
Dr. Bhalla?
see the this juxtanosmotic segment.
Yeah, so Dr. Adil, there are two questions. One is that per operatively, how will you know what are the features of a successful angioplasty? And the second question is, what are the incidence of restenosis? So I would frame it this way: that one is, how do you know that you have successfully, done a successful angioplasty? And can we, before sending the patient for an angioplasty, can we assess that we're going to have a high restenosis rate in this?
Yeah. See, when you go for the angioplasty, if for the veins, actually, not for the arteries, for the veins, I prefer to go for, because there are multiple studies of the inflation of 1 minute to 3 minutes. I generally prefer to go for the 2.5 to 3 minutes of inflation time of the balloon, and then when you deflate and then get a check angio, if there is a recoil more than 50% or more than 30%, that means that your angioplasty is not successful. You can try again and again till it goes when there is no recoil of around 30%. And if it is recurrent recoil, then that's an indication for the stent also. And for
Dr. Adil, what happens in most of the cases that, see, it's good that, you people are doing angiography, angioplasty. Most of the time, we are sending our patients to vascular surgeons, oblique intervention nephrologists. So when a patient comes back to us, the surgeon and everybody says it's done. But how do we assess that whether it's going to last or not? That is what I think is the question everybody has been wanting to know. How do you do it?
That's what I'm saying, that the recoil, if the recoil at the time of the angioplasty is more than 30%, that means that lesion will recur. And when you do the angioplasty, so some lesions are very tight. So, and the venous fibrous lesions are very tight. Otherwise, the artery in the coronary, the inflation is around 4-6. At 4 or 6, it will give up. But for the veins, you have to just give the inflation of around 30-40. So you have a very high inflation device of 40 atmospheres, and with the very tough balloons, they're known as Conquest, very tough balloons we use. So you can put a pressure up to 40. So if you go beyond 30, generally the lesions will give up. Yes. And the recurrence is very less.
So Dr. Adil, if you have a recoil of more than 30%, so would you stent this lesion? What would you do per operative? Would you stent it or would you just leave it at that?
No, for stenting, yes. When I was in CMC, because the finance is the issue. So, but when there's a, I have made my policy that if the patient comes within 3 months of the plasty, or if the plasty you have done thrice the plasty and now fourth time he is coming, or the lesion is very recoiling, at the time of the plasty, you should go for the stenting. We have done stenting there for the peripheral fistula, for the peripheral, for the brachial, this cephalic vein and the basalic vein also. Yes. And for the central veins, generally you may need of stenting after 2nd or 3rd plasty. You may need, because they are very tight lesions, very recoiling regions.
Okay. Dr. Ravi, please. Dr. Ravi.
Yeah, so there are much appreciation about the talk from the organizer. Do we have more time to ask questions, Dr. Vinod?
Yes, yes.
Okay,
so we have just about a minute, sir, if you want.
Yeah, so if
Half
there are other questions regarding the amount of blood loss which will happen in such procedures, and what are the costs involved, like if general angiography, what is the cost, or angioplasty, what is the cost? If you are a government setup, then maybe what is the cost of consumable, at least we should know, so that we can give an idea to patient.
Yeah. So we have we need a introduce a needle set, that micropuncture needle set. But to decrease the cost, we can take a needle only, the needle that we use for the cannulating for IGD. So that costs around 150 rupees, and the guide wire it costs around 200 rupees, and then the sheath it's around 1600 rupees of the sheath, and then the guide wires costs around 2000 rupees. And so the cost is of balloon cost, if you are using the conquest balloon, it costs around 16,000 rupees with the inflation device of the 2000.
Okay, so
But
Dr. Rajesh Jain has a question.
Do we have any structured study regarding the restenosis rate between the venous angioplasties and the arterial angioplasty, comparative studies? Dr. Adil.
Yeah, for venous angioplasty, yes, we have, not with the arterial stenosis, no, but for venous we have. So the restenosis rate in the venous is more than the arterial, because they are very fibrous lesions, they are very tight lesions, because there's a long-standing irritation due to the catheters, and they are, it depends on the chronicity of the lesion actually. So more the chronic lesion, more will be the fibrous tissue, and less chances of the successful plasty and the patency. So plasty is successful, but patency rate is the problem. So patency is not more than 3 to 6 months. Some patients come within 3 months, but yes, if there's a less tight lesion and less fibrotic lesion, particularly juxtaanastomotic lesions with small thrombus in the near the fistula, you can salvage those those fistulas. Yes, definitely.
One more question. Suppose pre and post stenotic venous diameter of around 10 millimeter, will you use a balloon of 6 mm, or you will really dilate it to 12 mm?
No, first we have to do the serial dilatations for that lesion.
Okay.
If the corresponding vein is around 10 mm and the lesion is, for example, you have done the angio and your lumen is around 2 or 4 mm. So you have to first apply the 6 mm or 8 mm balloon, then serial dilatation with the 10 mm balloon and the 12 mm balloon. It should be generally the rule that you should go 2 mm higher than the corresponding vein.
That's true. But you see, the rule of 6 says that 6 mm is sufficient to have an adequate flow.
Yeah, yeah.
If 12 mm, if we'll make a diameter of 12 mm, then the flow again will be tremendous, maybe 1200, 1500 ml per minute.
No, for the 12 mm, it will be the central vein. For the peripheral, yes. If it is a peripheral segment of the vein, yes. For that, not that much. But for the central vein, definitely.
Majority of the time, pre-stenotic dilatation is too much, even in the peripheral veins.
Yeah, definitely.
Okay, thank you.
So I think if there are
Okay,
no other questions, yeah, Dr. Balla.
Dr. Adil, yeah. So, Dr. Adil, one very basic question for a central venous stenosis. What would be preferable? Either do we angioplasty it or do we stent it?
So first we should try the angioplasty. If the patient came back within 3 months, yes, it's one of the indication that yes, we should go for the for the stenting. But we should try first the angioplasty. Sometimes a patient the patency rate is around 60-70%. Sometimes in for a year. So we have seen. I've seen few patients, they're still having no upper limbs swelling. They have the check angio, the repeat angio is, they have a patency, good patency of the vein. So we should try first the plasty. Then if they come, and even I have made my principle that I try plasty for at least 2 to 3 times, then 4th time I will stent. And if the patient comes within a month, then it's a indication for the stenting.
Okay, I think time's up. So Dr. Adil, thank you very much for the excellent presentation. And I would also thank my co-panelist, Dr. Ravi, for joining in and asking very relevant questions. And again, I would thank the organizers for an excellent session of intervention nephrology. Thank you. Thank you.
Thank you. Thank you.
Thank you, sir. We now move on to a masterclass, which is on central venous stenosis, approach and management. I invite the chairpersons, Dr. Mohan M. Rajapurkar, who is the Director for Postgraduate Studies and Research, and also a Senior Consultant at Mujibhai Patel Urological Hospital, Nadiad in Gujarat, and the second chairperson,
I think,
Dr.
Anupam, you have forgotten one session in between.
So we are going to have that session after this one, sir. Unfortunately, this speaker is a little, we're going to get him after the session, sir. Sorry, sir.
Okay, okay.
Right, sir. And the second chairperson for this session is Dr. Ramesh Jain, who's the Chief Nephrologist and Kidney Transplant Physician at Vardhaman Dialysis Center in New Delhi. I now invite Dr. Mohan M. Rajpurkar, sir, to please introduce the speakers and proceed with the session. Thank you.
Well, good morning, everybody. Welcome to this session. We have two very well-known nephrologists who have great experience in treating central vein stenosis. Hemant Mehta, who is the Chief of Nephrology at the Lilavati Hospital and Research Center in Mumbai. Huge experience on interventions as well as teaching students in nephrology. The second speaker is Dr. Valentine Dobo, who is a senior consultant nephrologist at KEM Hospital in Pune, a very well-known speaker and also a very high quality interventionist. So without coming between the speakers and you, I invite Hemant Mehta to start his presentation, please.
Good morning, everybody. Is it going to be me first or Valentine you want to start? Either way.
Hemant, you start with it, and
Okay.
then I'll be doing cases to illustrate certain specific points after that.
Okay, thank you. So, good morning. So we'll have this class with an illustration of cases for central venous disease and how do we approach it on a practical basis. I have nothing to disclose. So the outline of the talk would be when to suspect central venous stenosis, then how will you, if you suspect, how will you evaluate it, how will you assess the severity of obstruction, how to decide on lesions which require intervention, when to abandon the access by tying the AV fistula, when can a nephrologist attempt to intervene safely without any other assistance once he has acquired the skills to do it. And there will be certain video demonstrations of illustrative cases on the way as the talk goes on. So we start with a question. So have you ever seen a patient with thoracic venous obstruction that confounds the passage of catheter or causes swelling or other symptoms? Obvious answer is yes. All of us have had in the beginning or even now. cases, or when we were doing it, you attempt to put a temporary catheter and suddenly you find that the guidewire is getting obstructed, and then subsequently you find that there is in a central venous stenosis. That's a very, very common occurrence. So we have to define central veins, and central veins can be both defined in the upper limbs as well as in the lower limbs. But for the purpose of this talk, we will be only concentrating on the upper limb, and that's how we define the central veins here. It starts with the thoracic inlet up to the first rib on this side, and the similar thing on the other side. So this is how you identify it, and the subclavian vein, which begins at the lateral part of the first rib, and the axillary vein are not part of the central venous system. And then when we talk about central venous stenosis, we have had experience of seeing various kinds of hands with fistula and having problems. And I'm sure all of you would have seen that. So have you seen this kind of hand, severe central venous stenosis? Or if you see this kind of hand, but when you examine the full hand, it is just the palm which is got a problem and not the rest of the hand. So this is different from the first case. This is probably central venous stenosis. This is venous hypertension. Or if you see this kind of vein with a lot of collaterals, or if you see this which is all the way dilated, or again distal ischemia symptoms, scar which is just not healed and no veins visible here. So these are the different kinds of arms which we see. So this is another one with working fistula, but with an ulceration, blackness, and dilated veins seen all the way up there. And this is the problem. Probably there is a central venous stenosis here, or this kind of problems where there has been aneurysmal dilatation. So various problems occur. So let me start with this case. So this is very old case, and this was when in the era where subclavian vein dialysis catheters, non-tunnel, were used, and patient also happened to have a right radiocephalic fistula, and patient started having the swelling since 2005. At that time, patient was on dialysis, subclavian venoplasty with stenting was done, and AV fistula worked in 2019 when he had a cadaver renal transplant. So post-renal transplant, he came with this kind of hand. And what happened was that he had a stent fracture. So there was a narrowing again in the subclavian vein. So what was done was, after having passed the wire, in-stent plasty was done, and a stent was inserted within the stent. Over a period of 1 month, if you see and compare it with previous picture, the hand started regressing, and subsequently it became almost normal. And that was the time at which he was advised to undergo surgical ligation of AV fistula, though he was given a choice of endovascular occlusion, but he could not afford it further. So this was an abstract which was presented at ASN way back, and yes, what we found is that subclavian catheters are associated with high risk of central venous stenosis. Hence, we should never use subclavian vein unless there is no other option. And he had this in an era when this was not a recommendation. Also, stenting was not supposed to be done. In the present time, it is not a preferred method, but in those days, stenting was supposed to be the first method of choice. And what happened, the stent, because it was lying in the subclavian vein, and with the movement of the hand, etc., the friction, compression of the stent between the first rib and the clavicle, it subsequently fractured. There was a venous congestion, and so much so that we would have thought that he would lose his right upper limb if we don't do any intervention. So whenever we suspect that there is a central venous stenosis or otherwise when there are problems, we have to have cost examination. The basic principle of look listen and feel remains. So you look for such kind of issues. You inspect for central venous stenosis, you see dilated tortuous veins or unequal swelling between the two arms, or you look for signs of ischemia distally like this. So inspection is basic part of the problem to begin with, to evaluate and come further. And then there are two more. So look, listen, feel are the three tests one would do. And along with that, there is an augmentation test, and then there is an arm raising test. So these five constitute what one would call as 1 minute evaluation of a fistula. So of these, let us go through this video to see what is the arm raising test. And suppose this is the fistula, a question arises, are these aneurysmal, venous aneurysmal dilatations problematic, or they are okay and you can live with it? For that, you need to do the simple test, what we call as arm raising test, and see what happens. Just concentrate the vein, and then it just collapse, totally collapse. That means the venous drainage. Can you see the video?
Yes.
Actually, you want to start my video? Okay, 1 minute. Where is my video? Where's the-
सर आप अपना वीडियो ऑन कर
Yes. That's what. How do I do that?
thank
That's
you,
what I'm trying to do. It shows stop video. Okay. I've started my video. Can you do it, Ruchi, over on your side?
No, so you have to do it by your end.
No, but
Beside your mute option.
I think we could see the video when you first demonstrated. Maybe we should go further.
You could see this video?
Yes, we could see.
Yes.
You want to start my video, right? So this is how you see the collapse of the vein. And when you bring the arm back, again, the veins are nicely refilling. This is the study which you will do very easy for a bedside evaluation of clear venous outflow from the body of the AV fistula right all the way to the central vein. So this is the arm raising test which one can do. And then we come to this question as to how does central venous stenosis occur. And this could be related to certain devices like central lines of various kinds, whether it's the CVP line for ICU purpose, tunnel catheter, non-tunnel catheters, PIC lines, dialysis, cardiac rhythm devices, etc. But it could be unrelated to intravascular device. It could be idiopathic, extrinsic compression of the vein, dialysis associated venous thoracic outlet syndrome, and various other reasons. Now, what happens in dialysis patients? The high venous pressure and blood flow due to the fistula may overwhelm the collateral venous and lymphatic drainage, resulting in the development of dilated and tortuous collateral veins over the ipsilateral upper arm, neck, and upper chest. In severe cases, venous hypertension may eventually lead to disabling arm edema with pain and discomfort. Endothelial injury with subsequent changes in the vessel wall results in the development of microthrombi, smooth muscle proliferation, and central venous stenosis. So this is the physiology by which you get. And then, as we said, there are various factors which can precipitate it, and most of the time, with past history of a central line of any kind, patients are asymptomatic. It is only in the event when a fistula is made, and then the whole thing gets unmasked, and then there is the development of ipsilateral edema, breast engorgement, etc. And then when you go back to the history, patient will tell you, oh yes, 5 years ago I was in the ICU and I had a transplant. Something of that sort of history is something which you keep on getting very, very repeatedly. So for a busy nephrologist, what should be done? So one is, it's a very good habit to have examination of AV fistula and AV fistula arm by staff. So educate your staff. If they cannot do it on every day basis, every dialysis basis, they should do it on a weekly basis. If you have a vascular access coordinator, it is good, but whoever suspects should refer to the nephrologist for appropriate intervention. Diagnosis is based on history, physical examination, and then if you suspect it further, then you can suggest ultrasound, duplex ultrasound, which will show absence of normal respiratory variation with the diameter of central veins, polyphasic atrial waves. You can't visualize central veins with duplex ultrasound, but my suggestion is if there is a very strong clinical suspicion of a central venous stenosis, there is no point in wasting time, money, and energy on doing this duplex ultrasound, and one should be subjected straight away to conventional DSA, which will be diagnostic, and then if need be, also do therapeutic intervention. However, one must remember that not all central vein problems are due to endolingual pathology. So there could be presence of collaterals, there could be stenotic lesions which occur at the junction of the first rib and the clavicle. And then it is very important to recognize the external compression, because if you dilate the vein in that situation, then you are obviously the failure. But there are certain situations where you need to go beyond Doppler and choose either between computerized tomography, venography phase, or you can do an MR. And I'll give you one example of each. When you need to have a proper diagnosis, or what we call as appropriate venous mapping with a past history of recurrent multiple bilateral catheterization and patient coming with swollen arm, it becomes very, very important that we have to have a venous mapping with the help of some modality, so as to not only establish the diagnosis, but also to plan appropriate intervention. So this is how it is. So this patient came with breathlessness and at rest and intradialytic hypotension of recent onset, and she was told to have coronary artery disease because she was a diabetic and she was being prepared for transplant at another center. She came to us, so we saw all these things. She had dilated tortuous veins, so diagnosis was somehow patient landed up with cardiologist, coronary angio was done, which was dying normal. So then patient was referred to us and we said we'll do a CT to find out what it is and see what has happened. So you see this thrombus here at the tip, which Dr. Khanna is going to discuss further on, but I would like you to concentrate on this same patient's picture. So what has happened is that this patient, if you see all these collateral veins, means she has chronically obstructed central vein somewhere here. And if you see this thrombus around the catheter tip, that's something which appears acute, and that's why there is now acute dysfunction of the catheter. So this could be accurately diagnosed, and then subsequently you would obviously plan accordingly. As opposed to that, there are many situations, including lack of vascular access, because most of the time the CT people want to inject the dye fast and they need a cannula of at least 20 gauge or 18 gauge to be able to do that. And many a times our patients don't have that kind of a vein. So in such a situation, we have resorted to MR venography, and that's done with a time of flight protocol, no gadolinium, and see how excellent the results are. So if you see it on the left side, this is the MR venography of the central veins. Now look at the left IJV. You see some stenosis here. This is, and with knowing this, so obviously if you look at it, right side, you would not probably like to attempt because there is nothing visible either in the form of IJV or EJV. But over here, this is good. There's a stenosis here. So we punctured it here. This is correlated here. There is a stenosis. We did a plasty and we could easily put a tunnel dialysis catheter. So in such situation, planning and evaluating with some modality like CT or MRI will be of definite. And then once you diagnose it, what are your options? You obviously will consider angioplasty, with stenting for failed angioplasty, whether you would use stent grafts, whether you will consider primary stenting, and then lastly, whether this is the problem at the central vein level, or whether it is a high flowing fistula and you will do assisted bending or some other surgical flow reduction technique. So that also has to be remembered, that all central vein stenosis problems need not be tackled at the central level. You have to also look at the peripheral level sometimes. So this could be probably known by doing a Doppler study before intervening in such a situation. So let's take the example of this case, which was presented at ASDIN meeting in form of a video. So I would like you to go through it. So this is a patient who developed central venous stenosis with various other problems, and so it came with ipsilateral limb edema, hemifacial swelling, diminished vision, decreased hearing on the right side, throbbing headache, and this was 1 year after undergoing fistula. So this is his arm, and through this arm, they are puncturing him here and they are puncturing him here, and if you see hemifacial swelling, ptosis, etc. Yes, diminished vision. You see this dilated veins over the chest. So this is the problem with which he came. We did a Doppler. So there were abnormal waveforms in the jugular or subclavian vein, and that should prompt further evaluation. So patient was subjected to angioplasty. Aim was to study whole arterial and venous circuit in this situation. So we came with the femoral arterial route, and this was fine. So this was followed by the study of the fistula, and we found that this was a high flow fistula. Then we punctured the femoral vein and came all the way up there. And then there was this stenotic segment which was bypassed. Then if you see, there is a retrograde flow still in the veins up in the neck because of the stenosis here. So look at the shouldering on the balloon, which is suggestive that how now this has opened up. And now if you check the do it, still not a very satisfying result. So you would like to go in again with large size balloon, and again you are able to dilate it completely. Again you do check angio. Still the result is not very satisfactory. So, but if you see the collaterals have reduced, so this is the time when you put a stent, and this is how the stent is deployed. So a long stent. The most important thing you have to realize is that the brachiocephalic vein is coming to left side, and don't change it. If you do that, then in case you want to put a left sided tunnel catheter, you would have blocked the vein. So that has to be measured accurately. Once that is done, you do again a check angio, and always do instant plastic, at least once again. So that's done to assure that the stent is patent, and then this is the final picture. So that's how, see, within few days, hand has become normal, facial swelling has gone, the redness of the chest has gone. So patient is happy, we are happy, the fistula. You can see the dilated vein here. This could be used for the purpose of dialysis. So stenting for central venous stenosis is appropriate only when there is the elastic recoil of more than 50% following angioplasty, and if there is recurrent stenosis within a 3-month period, of angioplasty. Now the question is, can nephrologists do it, or you need some assistance? With basic training, simple cases can be definitely tackled by the nephrologist. You don't need very sophisticated setup. You need the basic items required has already been addressed to, and if there is a basic training in interventional nephrology, if you have access to Cath Lab, that's better. But for the insertion of tunnel catheter CAPD, even a CM should be okay. If you have an interventional radiologist, excellent. But if you're not, most of the centers now and cities now have interventional cardiologists. And to begin with, you can take help of cardiologists. They will be more than happy to assist you in this. So if this was a simple case, can the nephrologist do it? So this lady came with right upper arm swelling. And if you find that the cephalic arch and there is a stenosis at the junction here, so you're able to pass the wire, you do a plasty here, very easily doable. This is not a very difficult case. So if you see it again here, you're doing the plasty, and then yes, that's done, and then you have this narrowing has gone. So this is a simple case, which is nephrology. Or this lady had a right IJV TCC. She came with malfunctioning catheter. So after catheter pull back, we did a shoot. The tip was lying just here at the time point at which there is a SVCRA junction narrowing. So wire is passed all the way down, and then plasty is done. See, this is the narrowing here. You are able to dilate it completely. And then once done, you put a catheter, it's right in the right atrium. You can see nice outflow. And this is how you can tackle central venous stenosis at a simple level, nephrology. But what to do if you have something which is complicated, which needs more planning? So a 60-year-old male, right brachiocephalic fistula, right arm swelling. Hemodialysis initiated earlier with right IJV non-cuffed catheter 6 months ago, removed after 2 months. He is right-handed, disabled, he's got right arm swelling, his AV fistula has a blood flow of 1250 for a brachiocephalic AV fistula, and he's still being used, so the cannulation is difficult. And swelling has worsened over past 3 months. He can no longer use his arm to do day-to-day things. So this is the angiography, complete obstruction here, and what would one do in such a situation? So what is the first attempt to treat this patient's problem? For this type of chronic occlusion, plan would be to cross, and if necessary, well, as a stand. That could be one option. How will you approach from the upper arm? If this strategy fail, I would like to access the right common femoral vein and advance. So in such a situation, when you just don't know, what one would do is what is called as access and groin approach, which means you put one needle through the access vein in the right or left arm or forearm, as the case may be, because those veins are easily accessible, and you also go through the groin. You simultaneously advance your wires and catheters into a situation where you are able to take simultaneous shoot, try and cross if possible, and then you will try to do angioplasty if possible. If that requires, then you will do balloon expandable covered stent. But as I said earlier, don't change the left brachiocephalic vein when you're tackling the right brachiocephalic vein. And also consider decompressing the outlet with clavicle removal or first strip dissection in certain given situations. So you have three options. You do an angioplasty. I mean, not that you do everything in all the patients. You also consider decompressing it surgically, and you also consider reducing the flow of the fistula, either again surgically or with balloon assisted bending, etc. So if this fails, then one of the options would be to insert TCC and close the right bicuspid fistula and plan for a left-sided AV fistula. So that also sometimes has to be done in given situation. And if the second option fails, and if the venous hypertension persists despite flow reduction, then you would ligate the fistula surgically or endovascularly, plan for the access on the other. But prior to that, you can have these two options. So if there is a CTO, then these are the two new things. Zero, of course, is not very new. So this is a hybrid where you have central venous catheter going right up to the right atrium, and then there is this connection, and then there is this graft component, which is then attached to the artery here. So this is a cannulable zone, and this can be used. So there is a internalized central catheter, so to say. The other thing which has recently come up is what is called as a surfacer inside out device. And this is how you do. You have a complete obstruction here. You go from femoral vein here. This device which is placed on the skin where you want the, and then through this vein there is this sharp needle. We go through and through the tissue here and come out in the neck. Once you come out, you pull it back, push the wire in, and then put a tunnel catheter. So this is the totally occluded vein, and you go from inside to out to puncture. Normally we puncture from outside to in, but this is a device which assists you to puncture it the other way around. So this is one option. And then when we deal with this type of thoracic central vein obstructions, Society of Interventional Radiology has got some reporting standards. This has been published by Bart Dolmach. Bart Dolmach is one of the course conductor of the controversies in dialysis access, which is held every year or two at Medanta Hospital group. So the way this has been otherwise approached has been empiric and with very inconsistent literature and different definitions and different outcome measures. So we needed some, so this is what we would call as type 1 CTO, and this is what we would call as type 2 CTO. To establish this central vein work group was established, and this included people from surgery, IR, cardiology, nephrology, etc. More than 20 people worked for 3 years to develop this criteria, and then there is this type 3 CTO. You see a azygous vein and a subclavian vein, which is occluded above at the level. I'll show you similar case in one of my patients later on. So there are these reporting standards by which you define these TCVOs as type 1, which can be then divided into type A, B, C, D. This article can be accessed here, and then there is type 2, which is here, E and F. Again, you call it 2A and 2B, or you call you have type B here, and then a type 3 here, and then you have SVC obstruction that prevents a direct thoracic venous outflow to the right atrium with any constellation of tricuspid, interventricular, or subclavian vein obstruction. So these are the ways in which one has to divide, because as I said, if you are going to do some venous mapping, then you will have to find out as to what sort of obstruction you are dealing with, so that you can plan your therapy. And then when you report it, again, this has been standardized, so you have to report it with respect to anatomy, flow, symptoms, duration of symptoms, signs, performance status, whether patient has impairment or no impairment, anatomic pattern, and what is the impact on the patient care. So everything has to be reported. So this becomes very standardized method of reporting. And one of the major problem which is being found now, next to the repeated use of non-tunnel dialysis catheter, which are done multiple times and which has been emphasized by me and others on multiple occasions, that go for at least a tunnel catheter rather than resorting to multiple use of non-tunnel stiff catheters, which can predispose and increase the risk of central venous stenosis. It is the next one which is being recognized is the cardiovascular implantable electronic device. And again, this was a poster presentation in Atlanta last year. So this is one of the cases I will show you. So this patient has a pacemaker and a tunnel catheter, and this has been malfunctioning. Okay, so and what you found is that there is a narrowing here. If you see, this catheter is malfunctioning because of that. So you keep the catheter in, see again tight shouldering there, which means there is a tight stenosis. The another stenosis here. You try hard and hard and hard, keep on pressing. You have an inflation device, so you know what pressure what is your rated burst pressure. That is the pressure up to which you can go safely. In which case, 99% of the times the balloon would not rupture. So see this shouldering again, and you make sure that around the tip the vein is patent, otherwise again there will be a problem. And you do a check angio. Are you happy? Maybe you are not yet happy. So you would then go in for further angioplasty, so that you want to be sure that this is like totally open. So second angioplasty. See how this has become more difficult. We have to struggle and struggle and struggle till we get this complete dilatation, and then see this final. You are happy now. The vein is absolutely normal. The tip is free from any obstruction, and this catheter will work in presence of cardiac. So this is the summary of the case. So when we did the first shoot, this is what I was telling you, that there is an obstruction here, and that's why the azygous vein is filling. Number one. Number two, this is something which is scary. You start seeing the pericardium. So why does the pericardium fill? Again, same thing, because your azygous vein and crosses the pericardium before entering into the SVC, and because there is a complete obstruction here, the through the sinus, the pericardium was getting filled. So if you see this kind of a film, just don't panic that you have punctured the heart or something of that sort. And then, as I said, we did all sorts of dilatations, and then we managed to get into this proper working up. So, in our conclusion, we said that when we talk about catheter avoidance surgery, but we are still left with TCCS, sole vascular access. Also, when pacemaker with epicardial leads and leadless pacemakers are available, why should cardiologists not be encouraged to prefer these over the conventional catheters with lead? If that happens, it is also possible to have coexistence of two lifelines. Even pacemaker leads are lifeline and dialysis catheter is also. But one should try and avoid such a situation, and try and have it on the contralateral side, convince the cardiac, because we have had several cases where patients have come and they had a pacemaker earlier and substance made a fistula on the same side, or the other way around. So this should be avoided. So this is the conventional pacemaker. This is one of our patients where we convinced the cardiologist and cardiac surgeon to put epicardial lead, and this is how leadless pacemaker would be placed, and so that your central veins in both these cases are kept open. These were the cases with CKD, and this is how one has to approach the problem right up front. And then every time you are not going to get success. So when there is a need for a vascular access and your central veins are not amenable to plasties and stenting, you can have surgical options. So there have been instances of brachial artery to tubular vein bypass graft, or thickenous vein to loop transposition, superficial femoral vein transposition, axillary artery to popliteal vein bypass. If these also fail and the patient has a problem, then you will consider surgical closure of AV fistula. But you can also attempt endovascular closure, for which coils, glues, detachable and occluding balloons, and vascular plugs, MPLUGs vascular plugs are available. So just to complete the whole scenario, and before I leave and end this talk, for a future, we would be talking about two more things which are coming up in the central vein. One is what is the role of drug-coated balloons in treating central veins. We are now getting the large size balloons because, as you know, central veins are larger than peripheral veins. So there have been a lot of studies about using drug-coated balloon in AV fistula plasty, but as far as central venous stenosis is concerned, there is something which we still need to await for the long-term result. Number one. Number two, use of intravenous ultrasound for tackling central venous stenosis as exemplified in this particular picture. So this is the ultrasound probe here, and if you see this, oh yes, you have done good plastic, but no, if you do the ultrasound, you still find some muck sitting there and some here, and then now you do proper plasty, and now you see that vein has got totally clear. So this is something which will have to be done. Hopefully, we will have more on this by next avatar. We should be able to do it. So thank you very much, and for all those who are interested, I've had two articles. These are the references. This is a chapter, and one can visit that. Thank you very much.
Hemant, thank you very much. As usual, a very, very good presentation of some very good work that you are doing, as illustrated by the so-called simple to difficult cases that you have done. I think central vein intervention should be done by only those people who have taken trouble to train themselves very well. Its diagnosis should be something which all nephrologists should be able to do. However, if you're going to attempt a central vein plasty, then you be very careful that you have been adequately trained, or you have adequately trained people sitting with you. Without that, I don't think you should make an attempt to do central vein. You've shown us a lot of these things about what you can do and what is going to happen in future with intravascular ultrasound and also other devices. There are other intravascular devices which cardiology people use to make sure that from within the vessel, everything is all right or not. Now, while all this is very good, I would think that you should take a lead and form a group of people who in India do central vein stenosis to tell us by next avatar as to what are the results that we have got. How many times do we make a diagnosis? Two, how many times are we able to successfully tackle it technically? What are the complications encountered during the procedure? How often do these patients come back? What happens to their dialysis? Has their dialysis quality improved after the central vein intervention? Not only of your center, but maybe you should try and make a registry kind of a thing. I would think all those who do the central vein plasty should get together, maybe in an email group, and do that. So these are my preliminary thoughts, and maybe you could reply to them for about half a minute to a minute, and then I'll request my co-chair to invite the next speaker for a minute or so.
Thank you, sir, for your kind words and always, as usual, good words of wisdom. Yes, you are right that we should be having some sort of study. We do see cases being reported from all over India, but we also see that most of the papers which are coming up related to central venous stenosis are driven by interventional radiologists. So, because the patient belongs to a nephrologist, and the nephrologist refers the patient to interventional radiologist, and there is no coordination between the two. He does the plumbing job, sends the patient back, and patient still does not have relief of symptoms. But if the nephrologist is involved in the patient care and also during the procedure, he may not do it actually, but he should be able to navigate and tell the operator that, look, I'm looking for this result. So you do whatever is required to be done. Give me a good result. And then at the end of the day, this patient's fistula arm should settle down so that fistula is usable. That is the whole purpose. Now, coming to the question of technical success, sir, we have had technical success to the tune of more than 90%. Because we have now gone through.
Everybody knows your success. All my point I'm saying is that as a country, you should have a range.
Yeah. So I'm coming to that, sir. So, yeah, because that success rate will come with the technical expertise. So we need to improve the technical expertise.
Yes.
Yeah, that's what I'm coming to. That, okay, we have achieved something, but everybody needs to be like, sir, what happened 10 years ago with tunnel catheter and what is happening today, there's a vast difference because of efforts from the Avtar side to, propagate and teach people how to put tunnel catheter. So same thing, if we keep on propagating that this is what, because when I talk to my colleagues who are associated with charitable dialysis centers, all of them say there are plenty and plenty of swollen arms. Nothing is being done. We need to tap them.
Hemant, your point is well taken. All I'm saying is that all this data from within the country should be put together. That's about all that is my point.
Yes.
Okay. Anyway, I think we come to the end of this particular session. I hand it over to my co-chair, Dr. Ramesh, to invite Dr. Lobo and take it further.
Thank you, Dr. Rajapurkar. I have been
Sir, may I just interrupt, sir? So we have a little kind request. Dr. Jain? Sir, yeah, we have a kind request that the previous session, unfortunately, unable to do previous session because the speaker was unable to log in. He has requested us to do his session right now because he has to an emergency procedure. If I may request the previous session.
Fine. That's
can you please display the slide and we'll come back?
I have no problem with that.
Dr. Ramesh, sir, can we just come back again with the next session after this one?
Yeah, we can.
Thank you, sir. We now move on to our session, which is about.
Okay, may I request?
Yes, sir. Please go on, sir. So, can you hear me?
I can.
All right. So, can we proceed with the session, sir?
Okay. Thank you very much. I think, Dr. Vinant, you have told me to intervene in the intervention session. We come to one of the important areas, that is central venous thrombosis, that is the catheter tip thrombus management. And to do this talk is another very iconic figure, an important member of the interventional cardiology, that is Dr. N.N. Khanna. Dr. Khanna is a alumnus of KGMC Lucknow, and after his DM cardiology, he did a couple of fellowships and attachment in US and France because his interest was in intervention. Today, he's an iconic figure in Indian scenario for vascular interventions. He's senior interventional cardiologist and senior consultant vascular services at IP Apollo Indraprasth Hospital. I'll request Dr. Khanna to proceed with catheter tip thrombosis. We will come to the questions later on. And Dr. Himanshu, anything you want to say first?
Sir, yes, sir, let Dr. Khanna should complete his talk, thereafter we can discuss, sir.
Dr. Khanna, please.
Thank you very much for the kind words. I think Dr. Ashwini Gupta's screen is being shared, so I need to get the permission to share my screen. Can I share my screen because somebody is sharing the screen already? Can you hear me?
Ashwini? Ashwini?
Am I audible?
Yes, sir, you're audible.
You are audible.
We're just getting you on, sir. So hold on for half a minute, sir.
Dr. Khanna, till they are trying to finish it, how common are you seeing the central venous thrombosis?
So I'll come to that. It's not an uncommon thing which we see, the central venous stenosis. I was actually going through the talk of Dr. Mehta, and he comes to our center quite often to do these workshops that we work together. I've been doing this central vein stenosis for now more than 20 years, and the indications are the dialysis access catheters, and the other ones are the pacemaker wires and the bigger multiple ICD leads which we put sometimes. In my venous practice, about 40% of my patients would be having central vein stenosis of varying degrees. Not that every patient requires an intervention, but it is fairly common. And what it requires is a team approach. And I mean, we have been trying to make a team, but it's not easy to make a team because of varied logistic and interest issues. But it is very important because, as you said, and as Dr. Mohan Rajapurkar said, it is a very different ball game. If people just attempt without a proper training, you can have disasters. And Dr. Mehta would vouch with me if there are many cardiologists or radiologists who, if they just go in with a catheter, they create disasters, and there have been deaths on the table because the concept of central vein stenosis and the central vein the hemodynamics and the strength of the vein and the collaterals and the anatomy is not there, and what hardware to use. So it is a very different type of training. It requires a proper training and a proper learning curve. Only then it should be attempted. Because there are catastrophes if the operator is not very tuned to it and not very careful to it. You have to assess things and preempt things, and if there is a complication, do it right now. But if you don't and you just go in with a balloon and start dilating, you will on the table. And of all the people, I would say cardiologists who have specialized training in vascular interventions are the best people, because we are dealing with structural heart disease, and superior vena cava and right atrium is one of our areas which we intervene very often. And we know we have that tactile feeling, we know the issues there. But anybody can learn, but not all cardiologists are similar, but it only requires a proper training of vascular and structural, and only then it should be intervened. Also, if they are not fixing the screen.
No, sir, you have to share the screen, sir. We have given you full rights.
Is the screen visible now?
Yeah. Yes.
So I will go full screen. Okay. So let me speak about endovascular treatment of catheter-related intravascular complications. I can't move my screen. Okay, now I can move. Fine. So if you look at the catheter-related right atrial thrombi, there are two types. One is a RA thrombus, which is in transit. That means there is a clot along the catheter, and it just is transiting along the catheter into the right atrium. And the other one which we want to talk today is the CRAT, which is catheter-related right atrial thrombi. When you are looking at the CRAT, it is divided into two varieties. The type 1 CRAT is, or a type A CRAT is when the catheter, the thrombus is at the tip of the catheter, but it is loose, and has got a very high embolic potential. The type B or type 2 CRAT is when the thrombus is attached to the wall of the right atrium and or to the SVC, and it is a fairly fixed thrombus. Those thrombuses are very difficult to take out by endovascular means, and surgery is probably the only answer if it requires to be removed. Now, once you are talking about the central vein stenosis, what we see in our practice, venous practice, is about 20%. In my total practice would be around 8 to 10%. But when we are looking at the CRAT, the incidence is about 2 to 29% as reported in different literatures, because again, you have to have a high index of suspicion to actually look for it. It is fairly common in patients who have a long indwelling catheters, but if you're not looking for it, you may actually look at only when it's creating complications. Mortality related to it, it's about 18% in hemodialysis patients and 40% in non-hemodialysis patients, which are our cardiac patients, where we have devices going in from there or big leads, so multiple leads going from SVC into the RA, and the left ventricular functions and the right atrial functions are compromised. Now, once you look at the treatment options, it has to be individualized according to the extent of the intracardiac thrombus. You have to first do a catheter management, which Dr. Mehta has and the previous speakers have alluded on, how to actually, once you have a patient on indwelling catheter as an access for dialysis, how do you keep assessing that and looking for and even flushing with a TPA or some other thrombolytic agents to keep it patent and prevent the right atrial thrombus from forming at the tip. We normally small thrombi can be treated with anticoagulation, but the better thing is a thrombolysis, which could be used both in a systemic setting or a catheter-directed setting. I'll be showing you some examples of the cases. The other management could be a surgical thrombectomy or a percutaneous endovascular thrombectomy. Now let's talk about thrombolysis. It is, as I told you, it is reserved only for type A thrombi or type A crack, where the thrombus is loose and it is not attached to the wall. The agents which can be used are streptokinase, urokinase, and RTPA for systemic lysis. But for when it comes to a local lysis, you have to use a fibrin selective agent, which are only urokinase or RTPA or T-place. Advantage is that they are fibrin specific and they have a very short life, and they do not contraindicate any surgical embolectomy or a surgical procedure in case it is required. Now, what are the complications of catheter-directed thrombolysis? Once you are doing that, a part of the clot may get detached and it may embolize from there into the right ventricle or the pulmonary artery, or it may embolize into minor shower of emboli into the pulmonary circulation. But this is not much of a problem, because if you continue with lysis, most likely these thrombi are going to be subsequently lysed and the patient is going to do well, unless it's a big thrombus which has been embolized. The previous reports have not been very good on this technique, but this is an old literature, so an old presentation, so we'll not talk about it. Now the results are much more better. Previously, there were attempts to actually do a mechanical thrombectomy and take these clot out. There have been two reports. In both these reports, the outcomes had not been good, and therefore this procedure was abandoned and not developed further for many years. But in recent past, we started doing this, and we published, and then there was more technology-driven interest. And now we have a dedicated device called the AngioVac, which is geared up for removing large intracardiac thrombus, not only from the right atrium and the catheter tip, but from left ventricle also. But this device is not available in the country, and the disadvantage of this device is it sucks out a lot of blood, and that leads to a hemodynamic collapse. So sometimes we need to have a cardiopulmonary support as standby when we are using this AngioVac device for transfusions. Let me start with this background. Let me start with one of the cases which we did about 5 to 6 years back. And this patient actually regenerated our interest on managing right atrial clots which are at the tip of the hemodialysis catheter. And this was one of Dr. Jasuja's patients, a renal transplant rejection patient on maintenance hemodialysis. And he came in for a second transplant, and he had a history of pulmonary embolism in the recent past. And the workup sort of revealed large 6 centimeter thrombus at the right atrium attached to the right atrial blood wall, but very flimsily attached, and to the internal jugular vein catheter. We did a CT, and the CT, you can see on the CT, there is this negative shadow here, shows a big right atrial clot. And the same thing, if you see it in a different projection, you have a catheter, indwelling catheter with a large clot in the right atrium. And once you look at the transesophageal echo, what you see here is a big clot which is attached here. So now we had issues here. What are we going to do? Because this is a 6 centimeter clot. The size of the pulmonary artery is 2 centimeter. Suppose we lyse this clot is going to just go like a ball valve. It's going to get stuck at the right ventricular outflow tract or the pulmonary artery, and it will choke the artery and there will be a sudden collapse and there is no way to salvage this patient. We did offer surgery to this patient, and Dr. Gaurav would vouch that this patient refused surgery completely, and so we were left with just to think what should we do. And the patient was referred to me, and then I was sort of thinking what to do. Initially, we turned this patient down, but then I thought, like in coronaries and also in the devices which we put in and the aortic work which we do, many times there is nothing like a 6 centimeter clot. It's always an organized clot and an unorganized portion of the clot which is building over it. So we thought the first option let's do is to just start catheter-directed lysis and see whether we can reduce the size of the clot. So, and then see what we can do later on, whether it's amenable to endovascular management. Now, this is what we did, and surprisingly, when you this is post lysis, what you see that clot from 6 centimeter has reduced to 2 centimeter clot. You can appreciate it again if I can show you. This was the clot before, and this is the clot now. And so this was encouraging that we probably could do something, but still it had a high embolic potential. And therefore, we thought, let us do something. And I thought about it. I sort of went through all my devices which I had for retrieving foreign bodies from the circulation, but there was nothing fitting in. And then finally, I came across this is a retrieval device. This is a basket which has prongs in it, and it has a PTFE membrane which is inside. So it is good enough to trap, but this device is actually made to retrieve the IVC filter which we put in. So this is from Bard, and that we thought probably this, and the diameter here is about 3 centimeter, and we thought that this probably can work. So what we did was to do a bench test, and we took out that device, and we had a clot which we took out some blood and made a clot, and see whether this would work. And this is how we thought that the clot can actually be retrieved, and without the risk of embolization, it can actually be pulled out. So once this bench test was successful, the other problem was how to align the two. Here it's easy because we are aligning the two catheters, the thrombus and the catheter in one plane. But once you are doing a fluoroscopy, it is very difficult to align both of these in three-dimensionally aligned in a two-dimensional view. So we thought we will take transesophageal echo and fluoroscopy guidance, and with the help of a wire, we will probably have an axis where we can work. This is all what we require. These are components of the IVC filter retrieval devices. So this is a simple way, and we just laid it on the table. And then we went ahead and did a transesophageal echo and found that the best view to work on, and we found that this is a bicaval view where you can see the superior vena cava and inferior vena cava in one line. And this view probably would be the best. And then once we pass in a wire from the catheter, which is there for dialysis, and snare it out from the femoral vein, the wire is going to go in this direction, and we can bring the snare all the way from the retrieval device all the way from below on this line and try to dock under the fluoroscopy as well as TE guidance. So once we had this view, we actually were very, it was easy. We could actually go and dock the device there, and then we could open the device and catch the clot. We could see that on the fluoroscopy also, that we were coaxial, and we were we could be sure that we have collapsed the retrieval, and the thrombus is inside the fluoroscopy. And this was a result on the simultaneous transesophageal echo that the clot is more or less gone. And this was the angiogram which was done immediately. We see that the clot is gone from there. And this was the clot which was retrieved. Same thing, we did a CT angio which revealed and confirmed our diagnosis. So this was our first case which we actually presented and also published. And this created a lot of interest all over the world. So this was published in our Cath Cardiovascular Interventions. And this subsequently led to more referrals, and we also started doing more of these cases related to our devices and wires which we put, especially the embolized, detached wires in the right atrium and the right ventricle. This was another patient and who came in, a similar patient with a prospective transplant candidate. You can see a thrombus here. So I'm not going to be taking you through the same steps, but you can see there's a clot here, the big clot here, a big one. And you can see while we were doing it, whenever we are doing and trying to do something, we pushed in some air. So here, this is the pulmonary artery, which you can see with a little bit of air. That doesn't matter. So, but a huge clot in the right atrium, and if you can appreciate, all this is a big clot. This here. So, and if you see this, you would see this on a transesophageal echo. You can see the clot. You can see it's almost obstructing the tricuspid valve, and it is sort of flip-flopping across the tricuspid valve and has a very, very high embolic potential, typical CRAT A. So again, this is in a different view. And so we went ahead and started the same strategy. First was to do a thrombolysis to reduce the size of the clot. And you could see that the clot size is definitely reduced. You can, if you remember the previous picture, this is the clot size now, and I'll probably show you the clot size earlier. This was the clot earlier. And now after lysis, this is the clot size. So we could reduce it. And the second step was similar. But here what we did was we did a prolonged lysis, and we actually we did not do the lysis only from the catheter above, but we also placed a small catheter, which you can see side by side to this catheter, so that we can, because it was attaching to the wall also, so that we can lyse it in both ways. Then subsequently, this is our same technique to get coaxial docking wire, and we had a pulmonary catheter, small 4 French catheter into the pulmonary artery. This is only for a rescue. If this embolizes, we have an excess, we can immediately go, but put in a wire and crush the thrombus in the RBOT or pulmonary artery, so that the patient doesn't collapse. This is a retrieval thing, and that's why I say, whenever we are doing this central vein and right atrial thrombus, catheteric thrombus interventions, it has to be a team. It has to be a proper team which is doing it, which has been doing it regularly, and not that any doctor or any cardiologist or radiologist who gets an access or a referral should be doing it. So this is the final thing where we could retrieve the clot. And so we have been sort of developing this technique, and this is just a glimpse of our meeting, which is the Asia Pacific Vascular Interventional course. We did a 12th edition, 12th year in succession. Avatar, actually, we started with our second or third course, and we were doing the meeting together, and now it has grown to be a big separate meeting. So here, this time we discussed a lot of, 40% of our meeting is venous intervention, and there were major sessions on central vein stenosis and also dialysis access and RF and intracardiac removal techniques. And there were many workshops here. It was attended by 10,407 patients, also by our chairman, and one of the Nobel laureates actually attended, and he was very impressed by the meeting. We also discussed about stem cells and intravascular robotics and the central vein, how to deal with these thrombi by intravascular robotics. This is our experience of catheter tip interventions, thrombus interventions. In total, we have 15 patients. 7 patients had dialysis-related thrombus or the CRAT A. There was a venous excess-related issue in 6 and the PPI issue in 2. So these were all patients where we did something to actually remove these clots. The catheter-directed thrombolytic therapy was done in 15 patients, all of them, and 10 of them actually reduced the size of the thrombus that we had to leave it alone or pull back either the dialysis catheter or the venous excess catheter. In one patient, we had to send this patient for surgery because this was very adherently attached to the wall. And in 4 patients, we did similar techniques to remove this thrombus. So now we have, as I told you, now we have a, not that we have, but now there is a device available called the Angiovac device. It's not approved in India and not available in India, but approved in few countries of the world. The disadvantage is that it sucks out a lot of blood and it's very costly. The advantage is that it can actually, it's very well, and it can take out big clots from without the risk of embolization from either right atrium or right ventricle or even from the left ventricle. So I would stop here and I would be happy to take any questions which are there because that will be more informative and more for learning. Dr. Verma, you are muted.
Come mute over.
I said, Dr. Khanna, excellent presentation. The way you tackled your 2 cases, wonderful. Now the questions will be, number 1, when are you suspecting the thrombus? Because is it the increased pressure during dialysis? When do you suspect that a person is developing thrombus? Then we come subsequently to next questions.
Yeah, that is what I said, and that is why if you see the variability of the incidence reported in the literature, it goes from 2 to 27%. The first indication of the thrombus could be if it's at the tip and it's in the line of the flow, it will be a resistance to the flow. And it could be a resistance to one of the ports, you know. So that is the first thing. But I would sort of suggest, and I suggest to our nephrologists, and they do it, that periodically, once we are having this sort of issue, we must get a good echocardiography done, because it's very simple to view this catheter tips either in the RA or the distal part of the subclavian SVC. And you can see the thrombus there with much more clarity. And if the clarity is not there or the echo window is not good, you can actually do a transesophageal echo and look at them.
Now, secondly, now suppose now you have picked up a thrombus, you suspected it, you have picked up a thrombus. Because the option left with you are 3 only. 1, you can do thrombolysis. 2nd, you can do thrombectomy. And 3rd, you say surgical intervention. Now, when will you like that should we go for thrombolysis initially? Because the fear is always pulmonary embolism.
Yeah, only in large, that's why I said if the thrombus is very large, like in this, the first case which I presented, 6 centimeter thrombus in diameter in a RV outflow of 2 centimeters. So that if it detaches, it can just go and fit in like a ball valve and close the circulation. But if you do not have thrombosis like this, then it is a type A thrombus, which is not adherent and walled off. It is better that we give lysis, because even if it, if there is emboli, which will not be obstructive to the main pulmonary artery, the same lytic agent is going to go distally and lyse these clots. So we have to see what is the embolic potential and how large is the suspected embolus which will go. Like in the second case which I showed, again, the problem there was it had a very high risk of big embolization, because that clot was big and very loose across the tricuspid valve. And that is why when we did that, we also had a wire and a very small catheter in the pulmonary artery. If that happens, we can take a balloon and crush and put it distally. Apart from that, lysis is the best management. If it is a small one, we can even do systemic lysis. If it is a bigger one, it's better, and at the catheter tip, it is better that we do lysis through the catheter. Sometimes the clot is on the side of the wall of the catheter, not at the tip, and then there's no point doing a lysis from the catheter, because that is going to go distally and not affect that clot. So the best way there is to give a systemic lysis, or like the one with the second case, take another catheter from below, from the femoral vein, put it next to the catheter on the side, and then start lysing from there.
And if you have been successful in removing this, how long? 3 months you carry on with the anticoagulants? How much?
Yeah, after the best thing is after we have successfully lysed and removed the clot, it is better to change the line. because of course, if not, then we must anticoagulate for 3 months and do a surveillance. But it is better to change the line, because it is never ever that you are totally cleaning that catheter and making it free of clot. There would be a clot attached to the side and attached to the tips. So it is better to remove it. But then while you are removing it after doing a successful lysis or an endovascular removal, you may have a very minor emboli, but it doesn't matter.
A question, I think Dr. Himanshu, you take over. The last question, which has come from one of the audiences, to prevent formation of catheter tip thrombosis, will it be worthwhile using urokinase weekly, fortnightly, or monthly?
Yes, it's not a bad idea to use tissue plasminogen activator, maybe 1 or 2 milligram every week or every fortnightly after the dialysis, and lock these catheters. We do this very often with the, the chemo ports, with the surgeon's port and we put. But there now the chances of a chemo port occlusion and a tip occlusion with thrombus has come down to almost 1% in our hospital after we started this strategy. And they listened to us that, we just lock them with about 2 ml of TPA, 2 milligram of TPA and 2 ml concentration.
And thrombolytic of choice will be
sort of
TPA
takes
or
care of a
urokinase.
lot of things.
Thank you, Dr. Khanna. Yes, thank you, Dr. Khanna, for your very nice presentation. Actually, one question again, it's coming. Kindly, if it is, how frequently you can give this urokinase? Is there any study or is there any evidence on this?
When you are, if I understand correctly, your question is how frequently you can give it repeatedly in case of preventing thrombus or for treating thrombus.
Preventing thrombus.
Preventing actually 1 or 2 weeks, once a week or twice a week is good enough, quite adequate. And these have, as I told you, both these agents have very short half-life. And the amount which you are using is almost 1/20th or 1/25th of the amount you use for lysing acute MI or a pulmonary embolism. So it's a very, very minuscule dose. It actually works locally than systemically. And it is much better if you do it every second week or every second week, I would say.
Any role,
every week, otherwise every second week.
Any role of antiplatelet or oral anticoagulants on this to prevent this thrombus?
Yes, oral anticoagulants could be another option, but the type of patients like the dialysis patients, renal failure patients always have a very high risk with oral anticoagulants. So the risk of bleeding increases for no better gain for just preventing catheter tip clots. It's much better to give it locally and prevent that risk of bleeding.
In your 15 cases, what you said, Dr. Khanna, what were the catheter factors you analyzed? Was it the tip not at the correct place? Was it the catheter material? Was it multiple pores or anything on the catheter material? Anything you would like to comment?
I don't know for exact, but I have some impressions about it. The catheters which were like freely into the right atrium, were quite down, those catheters had more of thrombus at the tip. When I went to the literature, they say if you have a catheter at the SVC-RA junction, that is the best site for preventing the thrombus formation. The second thing, if the catheters were, not aligned and not freely into the RA, they had more, they had less risk. If they were more, they were like biased towards the right atrial or right auricular appendage. Those are like dead spaces near the wall. And there the clot formation is much more because the blood tends to stagnate there. These were two things. And the third one, which I would say, it's always the complexity of the catheter placement. If you have a catheter placed for a very long time, again, and did not have a proper surveillance, again, these patients had more chances of thrombus formation. But I can't be very sure about the material because I do not know, I didn't follow these patients. These are not my primary patients except the cardiac ones. And I really don't know how it affects, but I'm sure the newer ones, the newer permacaths, they are very good and the chances of thrombus formation there are much less. The ones which are Teflon coated.
One last question, sir. How many times you can do the thrombolysis thereafter you remove the catheter?
Or you can do thrombolysis any number of times, but it should not be it should be at least spaced 48 hours apart. If you're doing a full thrombolysis, that is all. And the half-life is so small, so little that you don't have to worry about it. We do that for peripheral arterial and venous thrombosis in our vascular work very often. We lyse them for 48, 72 hours. Sometimes we re-lyse them. Sometimes even post-op, post-renal transplant, we lyse them even after 12 hours, 6 hours. It doesn't matter because it's very localized.
I think
thank you very much, sir. Now it's we're concluding over to Dr. Vinay.
What we can only summarize with what Dr. Himanshu will agree. What you have conveyed is, one is the site of catheter tip is very important. Try that it is at the junction of SVC and atrium, which is the best place it should be. And second message you are giving is, it is pretty common. It may not be unwise to periodically review them, especially if you find that the resistance is coming more. And lastly, if you suspect and you diagnose that it is there, then you have to use a thrombolytic therapy. And possibly it may be wise also to use prophylactic thrombolytic therapy maybe every 2 to 3 weeks. Is that what we gathered from you, Dr. Bhalla, Dr. Khanna?
Yeah, definitely. That is the carry home message. And if you have complicated thrombus and central vein occlusions, I would agree with Dr. Mehta. It has to be referred to proper people who are trained in it rather than anybody or any nephrologist or radiologist or cardiologist.
I think, sir,
it's important because these things can be catastrophic.
Dr. Himanshu, you can conclude.
Sir, we can conclude. Thank you very much, Dr. Khanna, sir, for a very excellent presentation.
Thank you very much. It was indeed a pleasure to join this August meeting.
And I also Dr. Bhalla, Dr. Venan, Dr. Jasuja, and all the team for giving us this opportunity to enjoy this conference.
Thank you.
Thank you very much. Dr. Venan, all yours.
Thank you very much, sir. Extremely very informative session. With this, I'd also request announcement for the next session, which was actually, we had to break it into two, and many thanks to Dr. Valentine Lobo and the honorable chairpersons for allowing us to get the previous section back in between the session. May I please request somebody to kindly introduce the chairperson who can introduce Dr. Valentine.
Right. Thank you so much, respected speakers and chairpersons. I welcome again our chairpersons for this session, Dr. Mohan M. Rajapurkar sir and Dr. Ramesh Jain sir, and request Dr. Ramesh Jain sir to kindly introduce the speaker.
Thank you, ma'am. Thank you very much. Today's speaker on the central venous stenosis approach and management will be Dr. Valentine Lobo. He is a renowned interventional nephrologist and a senior consultant at KAM Hospital, Pune. May I request now Dr. Valentine Lobo to kindly deliver his talk. Dr. Lobo, please. Can you hear me?
Yes, sir. I'm trying to share my screen. Let me know if it is visible.
Not yet. Yes, now it is.
Okay. Am I audible also?
Yes, you're audible.
Thank you, sir. So Dr. Hemant Mehta has already covered in some detail the approach to central venous stenosis. So what I will be doing is only to illustrate some of the problems with cases. So this is one of my early cases, a 72-year-old diabetic ESRD who started dialysis in 2014. And like most patients, he started with a non-cuffed non-tunnel catheter and then had a left brachiocephalic fistula constructed. He developed an infection and the catheter was removed. Then he used a femoral catheter. Then he used a left internal jugular non-cuffed catheter. And in February 2015, he developed swelling of the left upper limb and his AV fistula became unusable because of that. He went back to a left double lumen femoral catheter, developed deep vein thrombosis and staphylococcal septicemia, at which time he came to KM. This is what his arm looked like, the fistula arm. There was a good thrill and a bruit present over the fistula, but the arm was so swollen that it was impossible to see or feel a vein which could be cannulated at this point of time. Of course, he initially went to the ICU. He required noradrenaline support, vancomycin and amikacin for his staphylococcal septicemia. We diagnosed him with a temp catheter to begin with. And once he had stabilized, I was able to puncture the fistula vein with ultrasound guidance and do an angiogram. And by bringing a catheter, as Dr. Mehta had shown earlier, up to the left brachiocephalic vein, this is the brachiocephalic vein, and there is a long segment of stenosis over here. The vein had a diameter of about 11 millimeters, and the stenotic segment was down to about 1 millimeter. Fortunately, it was easy to cross this with a Terumo wire and then plastiate with a 12 millimeter balloon, and this was a very gratifying result. Even more so, 48 hours after doing this, this is the state of the patient's arm. And here we can now see a nicely cannulatable cephalic vein. And this was a lucky one because 2 years later, when I last saw him in 2019, his fistula continued to be usable. This illustrates what happens, and this is I've taken the figure from the CKD Registry of India report in 2012, that 61% of patients in India get diagnosed at stage 5 and undergo emergency dialysis. Many of them would enter ICUs, they use rigid temporary catheters and then continue with those catheters until an AVF is created and becomes usable. There is a lack of screening. Frequently, the permanent access gets lost in patients. They then use a rigid catheter again as a bridge. They have multiple episodes of infection and eventually end up with central venous stenosis. This is not one of my own cases, but one which I found very interesting. It was reported way back in 2001 in the New England Journal of Medicine, and it was an atypical presentation. This was in the case records of the Massachusetts General Hospital, and they called it the effusion that would not go away. They investigated this patient's left pleural effusion in all manner of ways, looked for malignancy, looked for autoimmune disorders, looked for storage disorders, and could not find anything, and the effusion kept recurring. Ultimately, by going back to the history, they came to know that this patient had had a left subclavian central line catheter inserted 16 years earlier, and many years later developed an effusion. As the only presentation, the venous pressures were high, and once an angioplasty was done, it resolved. This is another patient of mine. She started dialysis in 2013 with a right internal jugular temporary catheter. A left radiocephalic AVF was attempted, it failed. We then put in a right cuff tunnel catheter, used it for 7 months, made a left brachiocephalic AV fistula, and since that became usable, we then removed the tunnel catheter. In May 2016, she began to develop a prolonged bleeding after needle removal. So we normally do not put tourniquets on our fistulas, just 10 minutes of pressure. But in this situation, the patient began using a tourniquet after her dialysis was terminated. And when we checked, her venous pressure was 240 millimeters of mercury at a 300 ml blood flow with 16 gauge needles. Her dialysis was fairly well preserved, the adequacy. There was no swelling of the arm, warmth or redness, but there was an aneurysmal dilatation seen proximal to the elbow. And as Dr. Mehta showed in the arm raising test, this segment did not collapse. So we took this patient for an angiography, and it would be very tempting to believe that this is the culprit lesion. You can see the aneurysmal dilatation here, and there is a stenotic segment. But if you look up here, there is also a stenosis in the cephalic arch vein and also in the left subclavian vein seen in the image on the right-hand side. So what this patient required was an angioplasty of all 3 lesions, which was done. Fortunately, they were soft lesions, just about 8 atmospheres of pressure was good enough to open them up. Her venous pressures came down to 180. The tourniquets disappeared until a year later, she once again had a recurrence of high pressures and bleeding and again tourniquets. And this time she had multiple collaterals seen over her shoulder, chest wall and neck. So we did a repeat angiogram, and what we found was that the lesions had recurred. And this time the lesion is tighter. Both these lesions are worse than they had been before, and they needed higher pressures this time to open them up. But fortunately, this is the balloon here, and there's a waist there. This is at about 12 to 14 atmospheres. It opened up eventually at 16 atmospheres of pressure, and the patient resumed the use of her fistula. It lasted for 2 years this time, and again in October last year, she began using tourniquets to staunch bleeding. The venous pressures went up to 220. and I did an angiogram expecting that the lesions would have recurred. But this is what I found on this occasion. The subclavian vein is fine, the cephalic arch was fine, but there was a complete occlusion of the left brachiocephalic vein beyond this point. So I was able to fortunately use a catheter. This is the roadmap, and using a real-time roadmap image and a catheter, I was able to get a wire across this lesion. This is the balloon dilatation that we did. We went with a 10 mm balloon here, and the result was very gratifying. It needed a high pressure, about 18 to 20 atmospheres to open it, but a complete opening, and she continues to use her fistula till today. This is the case of a 28-year-old woman, CKD5D. In March 2018, she started dialysis, as so many of them do, with a temporary catheter. She then had a right radiocephalic AVF, used it from May, sorry, that's not 2019, that's 2018, for 3 months. Then it failed, and she went for a left radiocephalic, primary failure. Once again, went back to a right IJV temporary catheter, which was removed in November for catheter-related bloodstream infection. She used a left femoral for 1 week, and then an attempt was made to reinsert a right IJV catheter, but there was a resistance to the guide wire. So what the operator did was to insert a very high catheter puncturing near the angle of the mandible, and said that there was a venous blood backflow in from the catheter. But when the patient was taken for dialysis, she had a very poor flows, less than 100 ml, about 80 ml, with venous pressures going up to 150 millimeters of mercury at pressures of 80. And that's when she came to us, and I punctured lower, the jugular lower, than the catheter, and it looks on first sight that this is fine. There is a free passage of contrast through the sheath which I have inserted, but this is the outline of the heart, and no contrast is entering the heart at all. And it's on the contrary, this vessel is going down below the diaphragm. So I took a lateral shoot, and what you can see is this is the SVC, and it is completely occluded. This is the temporary catheter, which is lying right at the tip of it, is lying right at that occluded segment, and it is the azygous vein which has dilated and filled up and is crossing the diaphragm, as is the internal mammary. So all the drainage is through collaterals to the azygous, to the internal mammary, and there is a complete occlusion of the SVC at this point of point. And when we passed a guide wire through the sheath and were able to cross it, now you can see the divergence of the two. So here is the guide wire. It is continuing through the SVC. It continues through the right atrium and goes into the right ventricle. And side by side, from my sheath, I was able to inject contrast, and I can see where the azygous vein, which is carrying the flow, is. I needed a 20 mm balloon to dilate this, and one of the things I found, a 20 mm balloon, as Dr. Beg said earlier, your balloon has to be, the sheath has to be sized to the balloon that you want to pass, and the 20 mm balloon required a 10 French sheet, which I did not have available. So since this patient was going to require a cuff tunnel catheter, what I did was to insert the sheath of the cuff tunnel catheter, which is a large sheath. It's about 14 French. So when I was able to insert the cuff tunnel, the sheath of the catheter, then I could pass a 20 mm balloon, and this is the tight waist here. It opened up eventually, and then after removing the balloon, okay, this is the balloon. There's a shoulder here, there's a waist here, so multiple points of stenosis. And now here the vein has dilated, and now contrast is seen to enter the right atrium. In this view, this is the sheath through which, the same sheath, and over the same guide wire, I was now able to pass in a cuff tunnel catheter, peel away the sheath, and I have a patient with a cuff tunnel catheter and an opened SVC and good flow. So that opens the question, should all central venous lesions be treated? Well, they have to be treated if they are severe and disabling. KDOKI and the European best practice guidelines say that percutaneous intervention is that of choice, with a technical success rate ranging from 70 to 90%. If it is symptomatic, then the complete outflow tract should be imaged and appropriate intervention done. So a patient who has cerebral venous hypertension, symptomatic arm, neck, or face swelling, the SVC syndrome, a progressive aneurysmal dilatation of the axis, significant static venous pressure, prolonged bleeding after dialysis will require an intervention. I like this study of Levitt's, which followed up 36 lesions, 38 lesions, on which 12 of which there was no intervention done and 26 were plastied. When they followed them up, of the untreated lesions, 4 improved, 4 remained stable, and 4 progressed, and none of them really needed any intervention. Of the ones which were treated, 26 that were treated, there was no, 62 were treated and 26 were followed up. 3 improved, but 23 progressed despite treatment, and 1 of them developed arm swelling, 4 developed additional stenosis, and 4 of them subsequently needed intervention. There were questions earlier about if we intervene, what can we expect? These are studies going from the late 1990s to early 2000s, and the rates at that rate were really not good. Primary patency of a pure angioplasty at 2-year patency was barely 10%. Secondary patencies, however, have improved, and now the secondary patencies, 1-year secondary patency is more than 80%, and 2-year about 65%. This is a summary of all the studies that have looked at interventions for central vein stenosis. 9 studies on primary percutaneous angioplasty, 10 on bare metal stents, and 5 on stent grafts. And these are the 6-month primary patency rates. 57, 61. Stent grafts do better, around 77%, and they also do better with assistant patencies going up to about more than 90%. So do I intervene in all cases? This is a patient who came to me for a cuff tunnel catheter because he had exhausted his limb accesses. He was a young boy. I think he was about 17 years old, and 2 failed fistulas, 1 in each arm. When I punctured the internal jugular vein, I simply could not pass a guide wire. When I injected contrast through the sheath, there was a complete occlusion here. There was no way to get beyond the head of the clavicle. And there was this huge collateral, which was as large as the internal jugular vein. It measured close to 1 centimeter in diameter, and all the contrast was draining through that from the rather than the occluded internal jugular. So what I did was, this patient wasn't willing for an angioplasty, and it would have been a difficult one unless one came from the femoral. I punctured the collateral here, passed a guide wire through the collateral, which could then bypass this occluded segment of IJV, and passed a cuff tunnel catheter through the collateral all the way into the right atrium, and it is still functioning pretty well. This is a patient of my own. He started off on maintenance hemodialysis in 2010. He had a very short use of a right internal jugular, switched to a radiocephalic left-sided fistula. The AVS thrombosed a year later. He then had a right radiocephalic, which failed, went to a right brachiocephalic, which was used for about 2 months, and then he developed progressive swelling, bleeding, and skin discoloration, and an angiogram showed a right subclavian total occlusion. So a stent was placed in the right subclavian, the symptoms resolved, and he resumed dialysis from his AVF. Till about a year later, he developed again swelling of the fistular limb and prolonged bleeding and high venous pressures. So I did an angiography through the fistula, and what it showed is, here's the stent, it's in place, but there is no flow of blood, of contrast through the stent. The advantage of having a stent there is, you can go with a roadmap, attempt to pass a guide wire, and you would know immediately when your guide wire stays within the stent. But here, my guide wire initially began turning from the cephalic arch through the subclavian and into the axillary. Using a guiding catheter, I was able to rectify that, get through across the stent, use a 12 mm balloon, plasty the stent, and here there's still a lesion here, there's a stenosis. So once again a plasty, and then it's better. There's a rapid flow because the fistula was a high flow fistula. So there's a rapid dissipation of contrast, and the lesion has opened up. So this was September 2017, opened up the lesion. He did well, and 6 months later, March 2018, again the same symptoms, and there's once again a narrowing of this point. So once more, I got a guide wire across it, dilated it, and once again opened it up. Yeah, this was a very tight lesion here, but it opened up, and he did well. But in July 2018, so now what was happening is, at progressively shorter intervals, the patient was requiring an intervention, and I had to go in July 2018, multiple points of stenosis. The tightest of them is here, opened it up. Once again, it opened, but 3 months later, the symptoms recurred, and this time the patient wasn't willing for an angioplasty. Dr. Mehta referred to the case that if you place a stent in the subclavian, ensure that you do not occlude the lumen or the opening of the left brachiocephalic. It wasn't, so we were able to place a cuff tunnel catheter from the left brachiocephalic, from the left internal jugular, and he did well with that. So summarizing the patency, I showed this already, so I can go past. So I just thought I'd bring in this. It's a patient who came in with multiple uses of both internal jugular veins. His right internal jugular had no flow. It was completely thrombosed. And this is the ultrasound picture of the left internal jugular vein. Now, what it shows is that there appears to be some lesion there, but there is patent vein on either side. And the Doppler shows flow on both sides at the central void. Our residents punctured it, but they found that the catheter kept going to the opposite subclavian. So I took the patient to the cath lab. I punctured the internal jugular, put in a sheath, and what I found was a holdup of contrast here and a trickle into the SVC and right atrium. So I tried to pass a guide wire under the roadmap, and this is what was happening. My guide wire refused, even though there's a patent SVC here, my guide wire refuses to go there. What it does is to turn and go up in this way, and beyond this point, it could neither move forward upwards, nor would it come down, no matter how I manipulated it. So I pulled my sheath back, and then I was able to take a fresh pathway, and my guide wire passed down. So what I was seeing here was a fibrin sheath. And when I click this, when I couple this image that I can see here with a holdup of contrast, you can see it filling the sheath over here, and the guide wire is passing from the side of the sheath, and that ultrasound image, I knew that we were dealing with a fibrin sheath. So back into the fibrin sheath we went, angioplastied it, and then passed a catheter. My last case, and this is one which I think Dr. Khanna alluded to the fact that one will get complications and need to know how to manage them. So this is a subclavian stenosis which I was attempting to plasty, and just as I got my wire across and was congratulating myself, the guiding catheter tip broke and sailed away down the guide wire. Fortunately, it came to rest over here. Now, one possibility would be to pull the catheter back, put in a snare it and bring it out, but there was a chance that when pulling it back that it would sail further down the guide wire or even off it. So what my cardiologist showed me was to do this. We took a 2 mm balloon, passed the balloon through the catheter, a coronary balloon, get the coronary balloon here. The coronary balloon, uninflated, goes through the tip of that guiding catheter. Then we inflated it so that it caught the catheter tip, pulled it back here, and then remove the whole assembly through the sheath and then start all over again. So to summarize, central venous stenosis is a complication of device use. The left brachiocephalic, probably because of the way the catheter rests in the vein, is the more frequent site for stenosis. Asymptomatic lesions are brought to light when a fistula, ipsilateral fistula is placed. All lesions may not require treatment. Angioplasty and stent use equally good results, and both of them require repeat procedures to maintain patency. Thank you.
Thank you, Dr. Lobo. A very nicely presented talk, and you touched almost all parts of the, all aspects of the central venous stenosis and its management, when to really intervene, should we really intervene or not, and how to intervene. And like I'm in coronary artery stenosis, say coronary artery disease, whenever there is a stenosis or a critical stenosis, the patient feels the pain. But in our central venous stenosis or a peripheral venous stenosis in a patient with AV fistula, they doesn't feel pain. They develop either edema of the limb, or there is a difficult cannulation because of the edema. The technician will tell us, also higher bleeding, delayed stoppage of bleeding from the fistula, poor dialysis doses, and maybe some cosmetic purposes. Many of the females say, my hand is slightly swollen, kindly do something for that. So there are so many reasons to really intervene, but we don't know which is the best really sort of indicator to have a preemptive fistulography and to diagnose the stenosis at the earliest, and then whether to intervene or not. Now I really open this session for the questions. So I have one question from Dr. Venkatesh Rajkumar. that what is the diameter of balloon used for SVC angioplasty to
Yeah.
Dr. Valentine Lobo?
Yeah. So the diameter of a balloon for the SVC would be probably between 16 to 20 mm. What I do is, if I can pass a sheath, we know that a 5 French sheath is 1.5 millimeters. So most Cath Lab machines, they have a method by which you can calibrate using the sheath and then measure the diameter of the vein, pre-stenosis, post-stenosis, and the stenotic area. So what is recommended is for veins, one can take a balloon which is 1 millimeter more than the diameter of the non-stenosed vein. So that is what I would do. Measure the diameter of the non-stenotic segment of the vein and choose the balloon accordingly, but it will be 16 to 20.
Okay, Dr. Venkatesh Rajkumar again wants to know, how would you advise to check for primary patency and assisted patency post-PTA, driven by the clinical indicators or a routine venogram at a periodic intervals?
So I go by clinical indicators, and perhaps one of the ways we are picking it up most commonly is prolonged bleeding. Now, we do not allow our nurses to put tourniquets on fistulas. So it's one of the ways of, if a tourniquet is put on a fistula and the patient goes home, then prolonged bleeding is not picked up early. So we pick it up fairly early by that method. Also, because a brachiocephalic vein doesn't have a great deal of tributaries. Also, if a basilic transposition is done, then the tributaries have been tied off. So in these situations, venous pressure and a trend of venous pressure which is rising, as I showed, immediately after plasty, the venous pressure comes down. At the same flow with the same needles, if the venous pressure is then progressively going up, that would be an indication for a venogram.
So Dr. Venkatesh Rajkumar again wants to know, what is your experience with the stent grafts? Is Viaban stent grafts available in India?
Fluency stent graft is available in India. I have no experience with stent grafts. They cost about 1.5 lakhs. So I have not yet had a chance to use it in a patient. Perhaps Dr. Heman Mehta has used them.
Yeah. We have used it in 4 patients and universally there has been restenosis even in the fluency stent graft. So nothing. Maybe the one which is not available is the Viaban graft from the Gore, because they have withdrawn from Indian market. So maybe those are supposed to be better, but I have no experience because they are not available. So yes, you can use. In fact, I would just point out that in the AV fistula venous outflow stenosis, we just had a paper presentation at STM in last February before the lockdown started, where we have presented 5 cases where, in absence of this small size covered stent graft, we have taken coronary stents, drug-eluting coronary stents in the venous side of the AV fistula outflow stenosis, and we had a 50% success rate over there. So that is one option one can be considering.
Dr. Mehta, I have one question for you. Do you have any sort of estimate which is the first thing to really appear? It is to suggest that there is a critical or significant central venous stenosis. Is it the edema of the hand, or say higher venous pressure on dialysis, poor dialysis dosing, or something else?
So as I said, see, your staff will be the ideal people to point it out. So now that staff has been trained, they will only point it out to you. Number one, that sir, venous pressures are going high. So that is first indicator that's, and secondly, they will again point out, as Dr. Lobo said, that there is a delayed clotting. So these are the 2 indicators which can be picked up. And of course, your KT/V value, which are now available online, would be falling, or the other way around, your biochemistry is worsening. So there have been patients whose creatinine used to remain pre-dialysis at 7, 8, suddenly starts remaining 12, 14, 15. Then you know that there is some problem in the vascular access circuit, everything remaining same. So these are some indicators where you will start thinking about it. Not that even if you suspect central venous stenosis, and even if you find that there is a problem, that you will need to intervene in all those cases. Because many times you do an angiography and the narrowing of the vein is more than not more than 50%. And obviously you will not do any intervention. Then just keep that patient under observation. So it's a variable thing. Nothing is, by the time patient becomes symptomatic, as I showed you in my case, with swollen arm, swollen face, diminished hearing, diminished vision, it's too late. So we don't need to wait till then. So we need to pick them up early and mark them. Look, this guy is going to be having trouble in the future. Observe him closely, maybe follow him up every 1 month, 2 months, more closely, and then intervene at the appropriate time.
There are quite significant number of patients with AV fistula has some kind of edema of the limb.
Yeah.
So where do you think, we should really ask for the fistulography when, if we look at the edema of the limb? Some people, some patient develop edema just after the fashioning of the AV fistula, and few patients develop it after, say, using it for 6 months or 8 months. So, and how much, do you think, is there any objective assessment that yes, now it is the time to really go for fistulography to rule out central venous stenosis?
First and foremost, we must remember that the cephalic vein fistulas are the ones which are very prone to develop cephalic arch stenosis. The cephalic arch stenosis is much more with brachial, cross-given fistula than radiocephalic. But not that radiocephalic fistula does not cause cephalic arch stenosis. So these are the lesions which will appear even in absence of any prior history of central vein catheterizations on the ipsilateral side. So that is something which has to be remembered. If it is not that, then the second possibility, of course, is that there has been a previous catheter history, maybe once, maybe multiple times, and those in the presence of a high flow which has been created by making an AV fistula start showing evidence that now, okay, the vein is undergoing stenosis. So these are the two situations which will have to be kept in mind. So once the swelling occurs, the first and foremost we'll have to differentiate is whether you are dealing with a central venous problem or it is just a venous hypertension. So that will have to be assessed with a Doppler and physical examination and Doppler. Once you are sure that you are dealing with a central venous stenosis, then you have various options. As I said, you can do a Doppler, you can do a CT venogram, you can do an MR venogram. And then if you think that yes, everything is pointing towards a lesion which needs to be tackled, the best thing is to subject the patient to DSA, identify the lesion, and then tackle it the way it needs to be tackled. At the same time, abandon not to treat if it is not a significant stenosis. So either way.
May I request Dr. Rajapurkar to kindly give his comments and opinions?
Well, I had already given those comments and opinions at the end of Hemant's talk. The same hold true even now. I think both of the speakers did such a wonderful job of showing us what can be achieved. But I would reiterate by saying that that is not everybody's cup of tea. We will have to be very careful. We will have to make an effort to go and train ourselves. Now, unfortunately, not many places have formal training for these things. Number two is, if you go for a training, what usually happens is you stand in a corner of a cath lab where if you're not very careful and if you don't have any prior background, one learns very little. So you have to approach a friendly interventional radiologist or a good friend cardiologist who would let you initially in over a period of 6 months to a year, as you start observing it more and more closely. Every single small movement in the cath lab is important, right from getting access to the vessel, putting hardware and things into the vessel, and finally doing the procedure itself. So I would say 6 months of observation, 6 months of assisted procedure, and then very carefully selecting simple appearing procedures to do it independently first. with keeping help available is the only way to go forward. Only after that should one attempt on a regular basis to do it. I did the same when I trained myself to do these things. In those days, at least there was nobody to tell me what I can't do. So I did it on much worse equipment than what is available presently. Equipment has become better. The hardware is becoming better. It's much more easier to do nowadays. However, that extra effort on the part of the nephrologist, if they want to become interventionists, will be to go through training, not only in conferences and attending, which are important, but if you're going to do it yourself, you will have to train yourself. And there aren't many formal trainings available. And the best way to go about is with a friendly interventional radiologist or a cardiologist to help you how to go about. Anyway, I think both of them did a fantastic job. So thank you very much.
Can we answer one question of Dr. Siddharth Vishwanathan? He has asked, in a tough switch occlusion, any useful wire catheter selection to help succeed cross? Okay, so when there is a CTO, chronic thrombotic occlusion, it is always a difficult choice. Now, what are your options? So your soft tip of a glide wire obviously will not be able to cross this lesion. So number one is you use the opposite end of a Terimo glide wire, okay, which is a tough one. Many a times you are able to drill in a passage just enough for subsequently to be able to pass a 0.04 coronary wire, and then you do serial dilatation over that wire and then create the passage. So that is number one. Number two, there are then some other devices which are available to cross this CTOs, but I mean, those are not available to us. So one thing which we have done now in about 4 or 5 cases is to use a long Shiba needle. As you know, Shiba needle is used to puncture the liver interventions, and they're supposed to be achromatic needles. So, and there are longer versions available which can be inserted right from the femoral and going all the way up into the central venous in the upper body. And with that, and then continuously taking pictures. And again, you need to be sure that you are aligned into the vein so that you are not going to rupture. So you'll have to continuously move your screen because most of our cath labs are 2-dimensional. So the projection will have to be AP, lateral, AP, lateral, AP, lateral, continuously. And then you find alignment, and then with a great conviction, you go in, puncture through and through, pass the wire. And this is absolutely tough, and it could be a disaster if you are not careful. So of course, these are done with the help of my interventional radiologist. I don't do such things alone, but this is possible. So, I mean, people do ask me a question about translumbar catheter, transfemoral catheter. Let me tell you, in last 3 or 4 years, we have hardly done any femoral or translumbar catheters, tunnel cuff catheters, long one, 45, 55 centimeters. The reason being, we have learned to cross over this totally occluded central veins with the help of some of the technique which is available, whether it is the patent natural vein which is occluded, or as Dr. Lobo pointed out, some collateral which is completely occluded, and we are able to cross over with what we call a sharp needle emulation. So that's possible, but that's something which is at a very advanced level.
Well, thank you, Hemant, for the thing. I think I'll hand it back to Vinant to conclude, or maybe Dr. Ramesh Jain wants to say something.
Thank you, sir. Thank you. It's a really very well presented talks, and we can close this session and head over to Dr. Anand.
Thank you very much, sir. And thank you, faculty, for having a wonderful day today, Sunday morning, with a lot of literature that has been discussed with Dr. Adil, and discussion on endovascular AV fistulas, hardware on fistulography and fistuloplasty, innovative ways to get catheter tip thrombus and how to manage them. And in the end, to sum it up with very beautiful case presentations and very practical tips on how to manage central venous catheter stenosis by two very well-known intervention nephrologists in this country, and also to moderate very good chairpersons. Thank you very much for your presence on this Sunday morning. And now I'll hand over the session to the final announcement that will be made for the next session. Thank you very much.
Thank you. Thank you, Dr. Vinant. I thank the respected faculty members, chairpersons and delegates for the wonderful session. And we're looking forward to seeing you again in the evening at 5:45 for the extracorporeal interventions in nephrology. So till then, please take care and have a nice day ahead. So we'll be again reassembling at 5:45.
With the aim of life longevity, the growth of medical science and change in its technical expertise in every sphere is phenomenal. To cope up with these changes, it's prudent for existing physicians and technical staff to enhance the skills of human intervention from time to time. In the field of nephrology, particularly in dialysis, vascular access, transplant or critical care, the patient's longevity and outcome depends very heavily on the ability of the physicians and their skills and traits of the paramedical staff. Understanding this pressing requirement of change to bridge knowledge gap, a body was created in 2012 called Avatar, Association of Vascular Access and Interventional Renal Physicians.
We try to fulfill our motto of Avatar Foundation by hosting annual conference, multiple workshops. We invite experts from all across the globe to showcase their work. We give a big platform to Indian young nephrologists to showcase their innovations, as well as to participate in the learning of various techniques.
The key area of hemodialysis is vascular access, vis-a-vis fistula, tunnel catheter or grafts. These are needed to deliver optimal dialysis. The dialysis industry keeps optimizing machines from time to time, while the execution involving technical skills stands as the greatest part of delivery. It has been realized that suboptimal delivery shortens life. The life of a dialysis patient in Japan is about 30 years, but in India it is only 6 months. To mitigate these differences, Avatar took up this challenge of optimizing delivery by enhancing the skills of physicians and their technical manpower. Avatar conducts 8 different workshops of dialysis segments to improve outcome. In the Cath Lab Workshop, we train central catheter placements, management of long and short-term complications, including angioplasties of central occluded veins as real-time opportunity in small groups. In SonoLab workshops, we train nephrologists and technical staff for use of ultrasound to locate access punctures and periodic surveillance for early rectification of any developing occlusion or malfunction. But the newer technique of creating AV fistula under sonography has been brought to India for the first time by Avatar in 2019. For dialysis nurses and technicians, we hold periodic classrooms and mannequin-based trainings to enhance their skills. For the first time in India, Avatar hosted and developed a curriculum for interventional nephrology with the help of 15 accomplished global teachers. The curriculum has been ratified by 10 premier nephrology training institutes of the country. We run Avatar classrooms for nephrology trainees regarding AV fistula, tunneled cath and BD cath replacement. These trainings are imparted by best of masters from across the globe. For past 2 years, we are hosting AV fistula and graft simulation workshops in collaboration with Vascular Access International of Switzerland. To map interventional nephrology resources at global level, we conduct regional leadership meetings. In 2018, we hosted 15 Southeast Asian countries, and in year 2019, 6 GCC countries participated, where we discussed strength, deficiency and resource mapping. This helps in understanding current status of interventional nephrology in regions and possible opportunities of collaborations in terms of resource exchange at low cost. Avatar Foundation has taken up the challenge to improve dialysis patient outcome by improvising surveillance in regular dialysis practices. In vascular access surveillance, Pan-India trial is underway to establish the desired practices, a fast-evolving trajectory into the future enabling new technologies, imparting more skills and expanding the expertise to deliver the most satisfying patient care.
With these effort of ours, which goes on round the year, probably we are able to deliver what we want to deliver to the society and enhance the patient care, patient longevity, and develop the field, and that's our passion. Thank you.
With the aim of life longevity, the growth of medical science and change in its technical expertise in every sphere is phenomenal. To cope up with these changes, it's prudent for existing physicians and technical staff to enhance the skills of human intervention from time to time. In the field of nephrology, particularly in dialysis, vascular access, transplant or critical care, the patient's longevity and outcome depends very heavily on the ability of the physicians and their skills and traits of the paramedical staff. Understanding this pressing requirement of change to bridge knowledge gap, a body was created in 2012 called Avatar, Association of Vascular Access and Interventional Renal Physicians.
We try to fulfill our motto of Avatar Foundation by hosting annual conference, multiple workshops. We invite experts from all across the globe to showcase their work. We give a big platform to Indian young nephrologists to showcase their innovations as well as to participate in the learning of various techniques.
The key area of hemodialysis is vascular access vis-a-vis fistula, tunnel catheter or grafts. These are needed to deliver optimal dialysis. The dialysis industry keeps optimizing machines from time to time, while the execution involving technical skills stands as the greatest part of delivery. It has been realized that suboptimal delivery shortens life. The life of a dialysis patient in Japan is about 30 years, but in India it is only 6 months. To mitigate these differences, Avatar took up this challenge of optimizing delivery by enhancing the skills of physicians and their technical manpower. Avatar conducts 8 different workshops of dialysis segments to improve outcome. In the Cath Lab Workshop, we train central catheter placements, management of long and short-term complications, including angioplasties of central occluded veins as real-time opportunity in small groups. In Sonolab workshops, we train nephrologists and technical staff for use of ultrasound to locate access punctures and periodic surveillance for early rectification of any developing occlusion or malfunction. But the newer technique of creating AV fistula under sonography has been brought to India for the first time by Avatar in 2019. For dialysis nurses and technicians, we hold periodic classrooms and mannequin-based trainings to enhance their skills. For the first time in India, Avatar hosted and developed a curriculum for interventional nephrology with the help of 15 accomplished global teachers. The curriculum has been ratified by 10 premier nephrology training institutes of the country. We run Avatar classrooms for nephrology trainees regarding AV fistula, tunnel cath and BD cath replacement. These trainings are imparted by best of masters from across the globe. For past 2 years, we are hosting AV fistula and graft simulation workshops in collaboration with Vascular Access International of Switzerland. To map interventional nephrology resources at global level, we conduct regional leadership meetings. In 2018, we hosted 15 Southeast Asian countries, and in year 2019, 6 GCC countries participated, where we discussed strength, deficiency and resource mapping. This helps in understanding current status of interventional nephrology in regions and possible opportunities of collaborations in terms of resource exchange at low cost. Avatar Foundation has taken up the challenge to improve dialysis patient outcome by improvising surveillance in regular dialysis practices. In vascular access surveillance, pan-India trial is underway to establish the desired practices, a fast-evolving trajectory into the future enabling new technologies, imparting more skills and expanding the expertise to deliver the most satisfying patient care.
With these effort of ours, which goes on round the year, probably we are able to deliver what we want to deliver to the society and enhance the patient care, patient longevity, and develop the field, and that's our passion. Thank you.
With the aim of life longevity, the growth of medical science and change in its technical expertise in every sphere is phenomenal. To cope up with these changes, it's prudent for existing physicians and technical staff to enhance the skills of human intervention from time to time. In the field of nephrology, particularly in dialysis, vascular access, transplant or critical care, the patient's longevity and outcome depends very heavily on the ability of the physicians and their skills and traits of the paramedical staff. Understanding this pressing requirement of change to bridge knowledge gap, a body was created in 2012 called Avatar, Association of Vascular Access and Interventional Renal Physicians.
We try to fulfill our motto of Avatar Foundation by hosting annual conference, multiple workshops. We invite experts from all across the globe to showcase their work. We give a big platform to Indian young nephrologists to showcase their innovations as well as to participate in the learning of various techniques.
The key area of hemodialysis is vascular access vis-a-vis fistula, tunnel catheter or grafts. These are needed to deliver optimal dialysis. The dialysis industry keeps optimizing machines from time to time while the execution involving technical skills stands as the greatest part of delivery. It has been realized that suboptimal delivery shortens life. The life of a dialysis patient in Japan is about 30 years, but in India it is only 6 months. To mitigate these differences, Avatar took up this challenge of optimizing delivery by enhancing the skills of physicians and their technical manpower. Avatar conducts 8 different workshops of dialysis segments to improve outcome. In the Cath Lab Workshop, we train central catheter placements, management of long and short-term complications, including angioplasties of central occluded veins as real-time opportunity in small groups. In Sonolab workshops, we train nephrologists and technical staff for use of ultrasound to locate access punctures and periodic surveillance for early rectification of any developing occlusion or malfunction. But the newer technique of creating AV fistula under sonography has been brought to India for the first time by Avatar in 2019. For dialysis nurses and technicians, we hold periodic classrooms and mannequin-based trainings to enhance their skills. For the first time in India, Avatar hosted and developed a curriculum for interventional nephrology with the help of 15 accomplished global teachers. The curriculum has been ratified by 10 premier nephrology training institutes of the country. We run Avatar classrooms for nephrology trainees regarding AV fistula, tunneled cath and BD cath replacement. These trainings are imparted by best of masters from across the globe. For past 2 years, we are hosting AV fistula and graft simulation workshops in collaboration with Vascular Access International of Switzerland. To map interventional nephrology resources at global level, we conduct regional leadership meetings. In 2018, we hosted 15 Southeast Asian countries, and in year 2019, 6 GCC countries participated where we discussed strength, deficiency and resource mapping. This helps in understanding current status of interventional nephrology in regions and possible opportunities of collaborations in terms of resource exchange at low cost. Avatar Foundation has taken up the challenge to improve dialysis patient outcome by improvising surveillance in regular dialysis practices. In vascular access surveillance, pan-India trial is underway to establish the desired practices, a fast-evolving trajectory into the future enabling new technologies, imparting more skills and expanding the expertise to deliver the most satisfying patient care.
With these effort of ours, which goes on round the year, probably we are able to deliver what we want to deliver to the society and enhance the patient care, patient longevity, and develop the field, and that's our passion. Thank you.
With the aim of life longevity, the growth of medical science and change in its technical expertise in every sphere is phenomenal. To cope up with these changes, it's prudent for existing physicians and technical staff to enhance the skills of human intervention from time to time. In the field of nephrology, particularly in dialysis, vascular access, transplant or critical care, the patient's longevity and outcome depends very heavily on the ability of the physicians and their skills and traits of the paramedical staff. Understanding this pressing requirement of change to bridge knowledge gap, a body was created in 2012 called Avatar, Association of Vascular Access and Interventional Renal Physicians.
We try to fulfill our motto of Avatar Foundation by hosting annual conference, multiple workshops. We invite experts from all across the globe to showcase their work. We give a big platform to Indian young nephrologists to showcase their innovations as well as to participate in the learning of various techniques.
The key area of hemodialysis is vascular access vis-a-vis fistula, tunnel catheter or grafts. These are needed to deliver optimal dialysis. The dialysis industry keeps optimizing machines from time to time while the execution involving technical skills stands as the greatest part of delivery. It has been realized that suboptimal delivery shortens life. The life of a dialysis patient in Japan is about 30 years, but in India it is only 6 months. To mitigate these differences, Avatar took up this challenge of optimizing delivery by enhancing the skills of physicians and their technical manpower. Avatar conducts 8 different workshops of dialysis segments to improve outcome. In the Cath Lab Workshop, we train central catheter placements, management of long and short-term complications, including angioplasties of central occluded veins as real-time opportunity in small groups. In SonoLab workshops, we train nephrologists and technical staff for use of ultrasound to locate access punctures and periodic surveillance for early rectification of any developing occlusion or malfunction. But the newer technique of creating AV fistula under sonography has been brought to India for the first time by Avatar in 2019. For dialysis nurses and technicians, we hold periodic classrooms and mannequin-based trainings to enhance their skills. For the first time in India, Avatar hosted and developed a curriculum for interventional nephrology with the help of 15 accomplished global teachers. The curriculum has been ratified by 10 premier nephrology training institutes of the country. We run Avatar classrooms for nephrology trainees regarding AV fistula, tunnel cath and BD cath replacement. These trainings are imparted by best of masters from across the globe. For past 2 years, we are hosting AV fistula and graft simulation workshops in collaboration with Vascular Access International of Switzerland. To map interventional nephrology resources at global level, we conduct regional leadership meetings. In 2018, we hosted 15 Southeast Asian countries, and in year 2019, 6 GCC countries participated where we discussed strength, deficiency and resource mapping. This helps in understanding current status of interventional nephrology in regions and possible opportunities of collaborations in terms of resource exchange at low cost. Avatar Foundation has taken up the challenge to improve dialysis patient outcome by improvising surveillance in regular dialysis practices. In vascular access surveillance, Pan-India trial is underway to establish the desired practices, a fast-evolving trajectory into the future enabling new technologies, imparting more skills and expanding the expertise to deliver the most satisfying patient care.
With these effort of ours, which goes on round the year, probably we are able to deliver what we want to deliver to the society and enhance the patient care, patient longevity, and develop the field. And that's our passion. Thank you.
With the aim of life longevity, the growth of medical science and change in its technical expertise in every sphere is phenomenal. To cope up with these changes, it's prudent for existing physicians and technical staff to enhance the skills of human intervention from time to time. In the field of nephrology, particularly in dialysis, vascular access, transplant or critical care, the patient's longevity and outcome depends very heavily on the ability of the physicians and their skills and traits of the paramedical staff. Understanding this pressing requirement of change to bridge knowledge gap, a body was created in 2012 called Avatar, Association of Vascular Access and Interventional Renal Physicians.
We try to fulfill our motto of Avatar Foundation by hosting annual conference, multiple workshops. We invite experts from all across the globe to showcase their work. We give a big platform to Indian young nephrologists to showcase their innovations as well as to participate in the learning of various techniques.
The key area of hemodialysis is vascular access, vis-a-vis fistula, tunnel catheter or grafts. These are needed to deliver optimal dialysis. The dialysis industry keeps optimizing machines from time to time while the execution involving technical skills stands as the greatest part of delivery. It has been realized that suboptimal delivery shortens life. The life of a dialysis patient in Japan is about 30 years, but in India it is only 6 months. To mitigate these differences, Avatar took up this challenge of optimizing delivery by enhancing the skills of physicians and their technical manpower. Avatar conducts 8 different workshops of dialysis segments to improve outcome. In the Cath Lab Workshop, we train central catheter placements, management of long and short-term complications, including angioplasties of central occluded veins as real-time opportunity in small groups. In Sonolab workshops, we train nephrologists and technical staff for use of ultrasound to locate access punctures and periodic surveillance for early rectification of any developing occlusion or malfunction. But the newer technique of creating AV fistula under sonography has been brought to India for the first time by Avatar in 2019. For dialysis nurses and technicians, we hold periodic classrooms and mannequin-based trainings to enhance their skills. For the first time in India, Avatar hosted and developed a curriculum for interventional nephrology with the help of 15 accomplished global teachers. The curriculum has been ratified by 10 premier nephrology training institutes of the country. We run Avatar classrooms for nephrology trainees regarding AV fistula, tunnel cath and BD cath replacement. These trainings are imparted by best of masters from across the globe. For past 2 years, we are hosting AV fistula and graft simulation workshops in collaboration with Vascular Access International of Switzerland. To map interventional nephrology resources at global level, we conduct regional leadership meetings. In 2018, we hosted 15 Southeast Asian countries, and in year 2019, 6 GCC countries participated where we discussed strength, deficiency and resource mapping. This helps in understanding current status of interventional nephrology in regions and possible opportunities of collaborations in terms of resource exchange at low cost. Avatar Foundation has taken up the challenge to improve dialysis patient outcome by improvising surveillance in regular dialysis practices. In vascular access surveillance, Pan-India trial is underway to establish the desired practices, a fast-evolving trajectory into the future enabling new technologies, imparting more skills and expanding the expertise to deliver the most satisfying patient care.
With these effort of ours which goes on round the year, probably we are able to deliver what we want to deliver to the society and enhance the patient care, patient longevity and develop the field, and that's our passion. Thank you.
With the aim of life longevity, the growth of medical science and change in its technical expertise in every sphere is phenomenal. To cope up with these changes, it's prudent for existing physicians and technical staff to enhance the skills of human intervention from time to time. In the field of nephrology, particularly in dialysis, vascular access, transplant or critical care, the patient's longevity and outcome depends very heavily on the ability of the physicians and their skills and traits of the paramedical staff. Understanding this pressing requirement of change to bridge knowledge gap, a body was created in 2012 called Avatar, Association of Vascular Access and Interventional Renal Physicians.
We try to fulfill our motto of Avatar Foundation by hosting annual conference, multiple workshops. We invite experts from all across the globe to showcase their work. We give a big platform to Indian young nephrologists to showcase their innovations as well as to participate in the learning of various techniques.
The key area of hemodialysis is vascular access, vis-a-vis fistula, tunnel catheter or grafts. These are needed to deliver optimal dialysis. The dialysis industry keeps optimizing machines from time to time while the execution involving technical skills stands as the greatest part of delivery. It has been realized that suboptimal delivery shortens life. The life of a dialysis patient in Japan is about 30 years, but in India it is only 6 months. To mitigate these differences, Avatar took up this challenge of optimizing delivery by enhancing the skills of physicians and their technical manpower. Avatar conducts 8 different workshops of dialysis segments to improve outcome. In the Cath Lab Workshop, we train central catheter placements, management of long and short-term complications, including angioplasties of central occluded veins as real-time opportunity in small groups. In SonoLab workshops, we train nephrologists and technical staff for use of ultrasound to locate access punctures and periodic surveillance for early rectification of any developing occlusion or malfunction. But the newer technique of creating AV fistula under sonography has been brought to India for the first time by Avatar in 2019. For dialysis nurses and technicians, we hold periodic classrooms and mannequin-based trainings to enhance their skills. For the first time in India, Avatar hosted and developed a curriculum for interventional nephrology with the help of 15 accomplished global teachers. The curriculum has been ratified by 10 premier nephrology training institutes of the country. We run Avatar classrooms for nephrology trainees regarding AV fistula, tunneled cath and BD cath replacement. These trainings are imparted by best of masters from across the globe. For past 2 years, we are hosting AV fistula and graft simulation workshops in collaboration with Vascular Access International of Switzerland. To map interventional nephrology resources at global level, we conduct regional leadership meetings. In 2018, we hosted 15 Southeast Asian countries, and in year 2019, 6 GCC countries participated where we discussed strength, deficiency and resource mapping. This helps in understanding current status of interventional nephrology in regions and possible opportunities of collaborations in terms of resource exchange at low cost. Avatar Foundation has taken up the challenge to improve dialysis patient outcome by improvising surveillance in regular dialysis practices. In vascular access surveillance, pan-India trial is underway to establish the desired practices, a fast-evolving trajectory into the future enabling new technologies, imparting more skills and expanding the expertise to deliver the most satisfying patient care.
With these effort of ours, which goes on round the year, probably we are able to deliver what we want to deliver to the society and enhance the patient care, patient longevity, and develop the field, and that's our passion. Thank you.
With the aim of life longevity, the growth of medical science and change in its technical expertise in every sphere is phenomenal. To cope up with these changes, it's prudent for existing physicians and technical staff to enhance the skills of human intervention from time to time. In the field of nephrology, particularly in dialysis, vascular access, transplant or critical care, the patient's longevity and outcome depends very heavily on the ability of the physicians and their skills and traits of the paramedical staff. Understanding this pressing requirement of change to bridge knowledge gap, a body was created in 2012 called Avatar, Association of Vascular Access and Interventional Renal Physicians.
We try to fulfill our motto of Avatar Foundation by hosting annual conference, multiple workshops. We invite experts from all across the globe to showcase their work. We give a big platform to Indian young nephrologists to showcase their innovations as well as to participate in the learning of various techniques.
The key area of hemodialysis is vascular access, vis-a-vis fistula, tunnel catheter or grafts. These are needed to deliver optimal dialysis. The dialysis industry keeps optimizing machines from time to time while the execution involving technical skills stands as the greatest part of delivery. It has been realized that suboptimal delivery shortens life. The life of a dialysis patient in Japan is about 30 years, but in India it is only 6 months. To mitigate these differences, Avatar took up this challenge of optimizing delivery by enhancing the skills of physicians and their technical manpower. Avatar conducts 8 different workshops of dialysis segments to improve outcome. In the Cath Lab Workshop, we train central catheter placements, management of long and short-term complications, including angioplasties of central occluded veins as real-time opportunity in small groups. In SonoLab workshops, we train nephrologists and technical staff for use of ultrasound to locate access punctures and periodic surveillance for early rectification of any developing occlusion or malfunction. But the newer technique of creating AV fistula under sonography has been brought to India for the first time by Avatar in 2019. For dialysis nurses and technicians, we hold periodic classrooms and mannequin-based trainings to enhance their skills. For the first time in India, Avatar hosted and developed a curriculum for interventional nephrology with the help of 15 accomplished global teachers. The curriculum has been ratified by 10 premier nephrology training institutes of the country. We run Avatar classrooms for nephrology trainees regarding AV fistula, tunnel cath and BD cath replacement. These trainings are imparted by best of masters from across the globe. For past 2 years, we are hosting AV fistula and graft simulation workshops in collaboration with Vascular Access International of Switzerland. To map interventional nephrology resources at global level, we conduct regional leadership meetings. In 2018, we hosted 15 Southeast Asian countries, and in year 2019, 6 GCC countries participated where we discussed strength, deficiency and resource mapping. This helps in understanding current status of interventional nephrology in regions and possible opportunities of collaborations in terms of resource exchange at low cost. Avatar Foundation has taken up the challenge to improve dialysis patient outcome by improvising surveillance in regular dialysis practices. In vascular access surveillance, Pan-India trial is underway to establish the desired practices, a fast-evolving trajectory into the future enabling new technologies, imparting more skills and expanding the expertise to deliver the most satisfying patient care.
With these effort of ours, which goes on round the year, probably we are able to deliver what we want to deliver to the society and enhance the patient care, patient longevity, and develop the field, and that's our passion. Thank you.
With the aim of life longevity, the growth of medical science and change in its technical expertise in every sphere is phenomenal. To cope up with these changes, it's prudent for existing physicians and technical staff to enhance the skills of human intervention from time to time. In the field of nephrology, particularly in dialysis, vascular access, transplant or critical care, the patient's longevity and outcome depends very heavily on the ability of the physicians and their skills and traits of the paramedical staff. Understanding this pressing requirement of change to bridge knowledge gap, a body was created in 2012 called Avatar, Association of Vascular Access and Interventional Renal Physicians.
We try to fulfill our motto of Avatar Foundation by hosting annual conference, multiple workshops. We invite experts from all across the globe to showcase their work. We give a big platform to Indian young nephrologists to showcase their innovations as well as to participate in the learning of various techniques.
The key area of hemodialysis is vascular access, vis-a-vis fistula, tunnel catheter or grafts. These are needed to deliver optimal dialysis. The dialysis industry keeps optimizing machines from time to time while the execution involving technical skills stands as the greatest part of delivery. It has been realized that suboptimal delivery shortens life. The life of a dialysis patient in Japan is about 30 years, but in India it is only 6 months. To mitigate these differences, Avatar took up this challenge of optimizing delivery by enhancing the skills of physicians and their technical manpower. Avatar conducts 8 different workshops of dialysis segments to improve outcome. In the Cath Lab Workshop, we train central catheter placements, management of long and short-term complications, including angioplasties of central occluded veins as real-time opportunity in small groups. In Sonolab workshops, we train nephrologists and technical staff for use of ultrasound to locate access punctures and periodic surveillance for early rectification of any developing occlusion or malfunction. But the newer technique of creating AV fistula under sonography has been brought to India for the first time by Avatar in 2019. For dialysis nurses and technicians, we hold periodic classrooms and mannequin-based trainings to enhance their skills. For the first time in India, Avatar hosted and developed a curriculum for interventional nephrology with the help of 15 accomplished global teachers. The curriculum has been ratified by 10 premier nephrology training institutes of the country. We run Avatar classrooms for nephrology trainees regarding AV fistula, tunnel cath and BD cath replacement. These trainings are imparted by best of masters from across the globe. For past 2 years, we are hosting AV fistula and graft simulation workshops in collaboration with Vascular Access International of Switzerland. To map interventional nephrology resources at global level, we conduct regional leadership meetings. In 2018, we hosted 15 Southeast Asian countries, and in year 2019, 6 GCC countries participated where we discussed strength, deficiency and resource mapping. This helps in understanding current status of interventional nephrology in regions and possible opportunities of collaborations in terms of resource exchange at low cost. Avatar Foundation has taken up the challenge to improve dialysis patient outcome by improvising surveillance in regular dialysis practices. In vascular access surveillance, Pan-India trial is underway to establish the desired practices, a fast-evolving trajectory into the future enabled